and my co-organizer, Larry Kleinman, for all of your terrific work in assembling a really spectacular group of speakers who will guide us through different aspects of our program today. And an enormous thanks to the Robert Wood Johnson Foundation. We thank particularly Kathy Malone from RWJF, who's joined us today, as well as some of her compatriots. And the Robert Wood Johnson Foundation has made this symposium, the whole series of symposia, as well as the New Jersey Healthy Kids Initiative possible. And again, thanks to our truly stellar group of speakers and panelists. We want to go over a few housekeeping points quickly. So I'm going to ask Chris Gunning to talk a little bit about that right now before we move on to the program. Chris?
Great. Thank you, Arnold. Yeah, so just a few quick house cleaning things. Those of you that are attendees today, if you have questions throughout any of the speakers' talks, please just enter your questions within the chat box. We have disabled the audio and video features for all the attendees just to try to minimize any interruptions of any of the speakers and not have people speaking over one another. So if you do have any questions, all of our speakers will be happy to answer the questions. We'll be keeping an eye on the questions coming in and be fielding them to the speakers. So please enter any of your questions there. The other thing that I would ask you to do, if you don't already, just bear with me for one moment. I'm going to share my screen for a second. Okay. Is to follow us on social media if you do not already. You can find us on Facebook and Twitter. You can also follow our YouTube channel. Our handle, excuse me, is just at NJKidsHealth. This right here, you should be seeing on your screen, is our Twitter page. And right now, during the month of October, we are partnering with the Move It Monday campaign for this Walktober campaign, where there's an opportunity to win a pair of free walking or running shoes simply by showing us how you are engaging in Walktober. So if you go to our Twitter page and follow us, we hope that if you're not following us already, please follow us today and share a video of how you plan to engage in Walktober. You'll see pinned to the top, we have several videos. We have two of my colleagues that'll be speaking later this afternoon, Dr. Paula Castro and Dr. Kamalo, explaining what Walktober is all about. And then you will see a series of other videos from some of our student ambassadors showing you how they are engaging in Walktober. So we invite you to follow us on Twitter, make sure you share a video, tag us, and use the hashtag Walktober, and share a photo or a video of how you plan to engage in Walktober for your chance to possibly win a pair of walking or running shoes. I'm going to turn it back over to Arnold to introduce our first speaker.
Thanks very much, Chris. We appreciate all the help. Very briefly, I'll keep my other remarks brief, as well as the introductions brief, but the symposium tackles a very large area, systems approaches to child health and well-being, and the idea being that children develop in the context of a series of concentric and overlapping interacting systems, from biology and genetics to psychosocial and societal systems, including family, extended family, the neighborhood, preschool, school systems, healthcare system, different levels of government and society, and of course the physical environment in which children grow up as well. And our speakers will address many different aspects of this complex tapestry. Our goal is to appreciate the breadth and complexity of these systems and to look for bridges and ways to broaden our understanding. And the idea really is that the real progress for well-being of children in the population comes in understanding the links, overlap, and downstream influences and effects of these systems. So with that pleasure, it's my pleasure to introduce my co-organizer, Dr. Larry Kleinman. I'm going to keep introductions fairly short. I could go on for a long time about Larry, but I don't want to take away from his time. But suffice it to say that he was a Rutgers graduate, MD from Wake Forest, pediatric residency in Connecticut, and in the National Health Service Corps in Connecticut, and then an MPH at UCLA, where he was a Robert Wood Johnson Foundation clinical scholar. He's traveled much of the country. And he's really developed expertise in measuring and improving health quality. He returned to Rutgers in February 2019 to serve as vice chair for academic development and help with a new division of population health, quality, and implementation sciences, pop quiz in the Department of Pediatrics. So I'll turn it over to you, Larry. Thanks so much again for your help, and we're looking forward to hearing you.
Thank you so much, Arnold, and welcome to everybody. I'm excited for the day. I'm sorry we're not all together in person, and I'm counting on the technology to carry us through. Chris, can I share my screen or?
Yes, you should be able to share your screen just by clicking the share screen button at the bottom.
Okay. Got it. And so I'm going to try to do a pretty rapid overview of a complex topic: systems measurement and systematic thinking for equitable maternal child health. And what I really would like to do is suggest the importance of explicitness and measurement in the design, interpretation, and conduct of the gathering of evidence, of research and evaluation in maternal child health. So I have a couple of slides that are really intended to be illustrative. This is older data, but it shows you that our national health expenditures are on the rise. But nonetheless, either our doctors are not as competent as those in other countries, or the systems matter. That's part of the underlying rationale for why this topic is so important. There are important distinctions between healthcare needs of children and adults. Chris Forrest and colleagues initially presented it as the 4Ds: the developmental status of children, the differences in the epidemiology of disease between children and adults, the fundamental dependence of children upon their caregivers, and the specific demographic patterns that are typical for families with children. They are younger families. They have less wealth than other families on average, and in fact are much more likely to be in poverty. Lower income is associated with higher mortality, both generally and even in narrower bands, such as among British civil servants. And the larger disparities in income are associated with worse outcomes across and within all income spectrums. I could not find up-to-date data because, as the New York Times reported yesterday, there are another 80 million individuals, another 8 million individuals in poverty that weren't several months ago. But there are tremendous number of uninsured children. Infant mortality at 6.7 deaths per 1,000 births does not place us well in the international spectrum. 18% in poverty. Somewhere between 10 and 15%, depending on the estimate I have here, 11.3, have at least one of 7 major behavioral mental health conditions. About a quarter of children, 22.3 in this estimate, have at least one chronic physical condition that defines it as requiring more than the usual level of care for more than 1 year. That's also known as a child with special health care needs. Almost 1 in 10 teenagers are neither in school nor working, and our death rate pre-COVID was 62,000 per 100,000 teens. So we need to improve the system because we need to improve the health of children. And that's really should be a call to action for all of us to do what we can to master our piece of the universe in some way as to contribute to improvement. This is a depiction of that. Generally, there is a policy environment, a physical environment, an economic environment, and then there is the overlay of discrimination, racism, and the lack of social justice. And within that, the child is nested inside of a family in under optimal circumstances, a community, populations, and then the public health system. So this is very much of a series of nested ecological interrelationships. Life course theory holds, among other things, that desirable outcomes of a pregnancy include both a healthy mother and a healthy infant raised in a healthy family where they're able to thrive and share in their growth and development in healthy ways over time. In other words, there is a positive aspect to health that goes far beyond the absence of disease. Desirable outcomes for childhood include a flourishing and biologically healthful young adult. So the role of childhood is not simply to get through it healthy, but to experience positive health, as well as to experience a healthy aging process in the future. The current state of health and well-being reflects the intrinsic biology of the individual, the sum of the impact of past experiences, exposures, and context, as well, and provides a starting point that is key influence of the future state of health. Resources and resilience to potential stressors are modifiable and can influence and do influence the health of individuals and populations over the life course. This life course approach suggests that health and well-being emerge in the moment, shaped by this variety of past experiences. It's foundational and it's responsive. So it's really a useful framework when one is thinking about the health of children or of families. The CDC has taken a slightly more static approach, defining the exposome as the measure of all of the exposures of an individual in a lifetime and how those exposures relate to health, with exposures beginning before birth and including insults from environmental and occupational sources. So the child's health is dependent upon the mother's health at the time that she gets pregnant, as well as the experiences of pregnancy. And it's a bit more biomedical and cross-sectional than the dynamic considerations of life course theory, which really comes from the maternal child health world. The life course model of health development posits that an individual's health trajectory is more than simply the combination of their genetic endowment or their lifestyle choices, and that social, psychological, and environmental factors that operate early in life can and do have major impacts on both short and long-term health outcomes. And it can provide us with vital information to model how investments in maternal child health can be more effectively targeted. And there's a very rich literature on the life course literature, and HRSA, the Health Resources and Services Administration, is an important proponent of this and of work that uses life course. This is another depiction that's a little more specific than that ecological one. It suggests that there are both determinants and modifiers of health and well-being that exist within the family and the community, and that we can identify them as distinct systems, including the physical environment, the educational system, the economic, the health and social services. Obviously, this is not comprehensive, but it does suggest, I like the roots on the bottom of this, because it's not only how well the daisy appears to our eye, but how healthy its root system is and how its capacity to be resilient to future shocks. This depicts the notion that there is leverage to life course thinking, that if you can intervene earlier, you may have greater impact, looking at the size of the shadows from the morning sun. It's always beneficial to improve things, but it may be more efficient to improve earlier with greater benefit that can accrue over the course of a lifetime. This is different from some of the economic thinking that would discount future health in its extremes, so that interventions on children often are barely perceptible when doing some cost-benefit analyses. I want to stop for a moment to talking about life course, to talk a little about epistemology. I call this a philosophical reflection, because all of the work we do relates one way or another to uncertainty. And philosophers talk about two types of uncertainty: epistemic, which is a shortage of evidence, and aleatory, or what we might think of as stochastic or statistical, which is that processes are imperfectly linked to outcomes. The classic medical phrase of this is the operation was a success, but the patient died. And aleatory uncertainty makes it a challenge to learn, because it's harder to distinguish signal from noise. And it also may put a time distance between when we experience something and we can conclude something. In philosophy, a classic definition of knowledge is a true justifiable belief. But in our world where our evidence and our knowledge is always changing, I think of it as belief reasonably justified by evidence. There are counterexamples to this, but it is still a pragmatic definition. And how and by what do we accumulate evidence? The positivistic approach that has been dominant over the years, defined by Karl Popper, is we use inductive reasoning by testing theories, and then we accumulate confirming evidence, which only counts when it's the result of a genuine test of a theory. So this is the call for the scientific process. Evidence-based medicine is another thing that bridges both philosophy and practice. It's evolving as the dominant philosophy in healthcare. The term was originally coined by David Eddy in 1996 while looking to identify what practices should be paid for by insurance, so very different than we think of it now. A survey in 2010 said that the public perceives evidence-based medicine as a backdoor to rationing by insurance companies looking not to pay. And I suggested way back in 1998 that it's logical to think about the availability of evidence before requiring things or asking for things to be evidence-based. And this really reflects the fact that we're living in a world of uncertainty. The semantics are somewhat misleading to the disadvantages of patients and physicians and in favor of insurers, not surprisingly, giving the words etymology, the term's etymology. It diminishes the profession and the practice of medicine in part through language. So it refers to doctors and nurses as providers rather than clinicians. Providers are not necessarily professionals, they are simply deliverers, whereas clinicians exercise judgment. So I try to make this point when I can, because the word provider has become dominant, even though it is deprofessionalizing. It offers a promise unfulfilled that sufficient evidence exists to guide most clinical decisions. I'll show you why that's even more true in pediatrics. And at some level, it delegitimizes the once powerful role of the physician as a healer and even as an advocate for the patient. If you're simply a provider, your job isn't necessarily to think, certainly not to speak out. So this is a very simple depiction that we have what we do, which stems from our belief. Research can turn that belief into knowledge. There's a small portion of what we do that research has taken place, and that allows for an evidence-informed clinical practice. But evidence is particularly limited when it comes to child health. It's a much smaller band of research that's been done, the clinical knowledge. Therefore, the opportunity to have evidence-informed practice in children is reduced. And this is an old PubMed search. I've redone it since, but I didn't record the numbers. I just confirmed that this disparity was still true. If you look for effectiveness research, outcome research, or clinical trials, there are massively more, orders of magnitude more for adults than there are for children. So this is why that band is so much narrower in children. And if you think about it, child health is probably even more defined by stages and developmental stages than is adult health. So it might be appropriate for those numbers to be reversed given the span of material and the developmental influences of on health and healthcare. Now I'm going to just, so the uncertainty index is a way that I have used to describe this difference. It's the proportion of unrefuted care that has also not been corroborated. That is a really lot of negatives in that. Unfortunately, given the way that we make null hypotheses, this is really the correct way to state it. And I haven't figured out a simpler one. I would welcome somebody providing me that. But it's the proportion of care that has not been shown to be ineffective and that we lack evidence is effective. So in this little simple diagram up here, it's blue over green. which is, sorry, blue over blue plus green, which is larger than it is in this one. And therefore, the uncertainty index allows us to be more explicit in terms of thinking about the level of evidence that we ask before we believe something to be true, or at least before we use it, and hopefully continue to evaluate it. Clinical medicine and public health practices are both evolving practices with an ongoing advancement to their scientific base, and they need to integrate science, caring, pragmatics, and business, because they need to be paid for, particularly healthcare. And that, I think, in some ways is unfortunate, because the profit motive can be difficult even in a not-for-profit setting, where margin rather than profit is what drives a lot of work. But the opportunity for gain comes in the form of learning. So we translate basic sciences, we apply it, we can document key structures, processes, and outcomes of healthcare or public health practice, and create a learning culture, learning organizations, and a spirit of ongoing improvement. And creative measurement may enhance the opportunity for learning, enhancing and helping to develop a community of practice where we learn from one another and we share tools. And it suggests a reason for teamwork. I thought in this fractious season, electoral season that we are in, it was worth taking a moment to realize that maybe we actually can work better together rather than in competition and in rivalry. And a community of practice is defined as a group of people that share knowledge, learn together, and create common practices to the benefit of all by enhancing the accumulation and sharing of knowledge. It promotes innovation, flexibility, and productivity. Communities of practice have shown to develop better work relationships, improve morale, and increase longevity. They reduce burnout, and they shorten the learning curve. That shouldn't be leaning curve. Shorten the learning curve, the time from discovery to proof of concept, and from proof of concept to adoption. So that makes me think about innovation, and I have a little different view of innovation than many. I believe innovation is primarily the systematic reduction of uncertainty regarding both what is our facts and fundamental knowledge, and also regarding how to do things. And that relates to implementation science and the application of knowledge. And then secondarily, innovation incorporates the application of inspiration to reduce uncertainty, which may again be fundamental research or applied. In any case, I think that we sometimes think of inspiration as that eureka, or innovation as that eureka aha moment. But I think it's really the systematic preparation for that aha moment. And that's borne out in that one of the major differences between Nobel laureates and others is the amount of time they devote to their work, Nobel laureates in the sciences in any case. So if the purpose of measurement is to reduce uncertainty, I would argue that my pragmatism takes us to say that in a way that ultimately leads to improvement or betterment. This shows it with clinical practice, but it could be clinical or public health practice, or other things that we do and know, that we develop metrics that allow us to learn from them, we apply them within practice, and then it's our job to use them to make health better. I show this as a quality frame, but you could really have the left axis any positive attribute that you want, or you could have a reduction of uncertainty. But I think that these are iterative processes that take place over generations and lifetimes. That's not to say we don't make important discoveries in the moment that can have immediate change. We certainly can and do. I think that the larger picture is important to remember and keep in mind. And there are many reasons why we may not find what we expect to find. So this shows degree of improvement and the relationship between need and readiness simultaneously. So a community that that needs a new technology, say, but has no one in it who's capable of using that technology, may have high need and low readiness, and applying and bringing the technology in would not lead to improvement unless you also brought that other missing factor. Similarly, improving the schools might not lead to improvement in educational outcomes if you don't feed children first so that they're ready to learn. And then at the other end of the spectrum, it may, in fact, failure to show improvement may represent that the community had a lower need rather than the intervention is fundamentally not valuable. And I think that the diversity and the variability shown on this slide is a rationale for both systematic thinking, for trying to understand and model systems, and it explains why I included implementation sciences in the name of the division that I came to lead, Pop Quiz, as Arnold mentioned. This suggests that there may be different time trajectories to benefit. And so if you think about these as showing benefits over distinct time, if one were to evaluate here, these lower curves would appear to be ineffective because their benefit comes later. And one thing that was true for has been Head Start, where there was originally the comment that the effects and the benefits of Head Start, which were initially seen, so actually were here, were extinguished over time and came down like this. And that was believed until some people did interventions in children with and without Head Start. And those who had had Head Start were much more prepared and did much better in the later interventions. So it's really important to model and think these things through before concluding that something either does or does not work. Planning and thinking about the meaning and the implications of your topics and your work is incredibly important. I'm going to stop here, and now I have to figure out how to get into the chat because I didn't realize. Is there any way, Chris, we can turn the sound on for people for a moment? Because I really wanted a brief interaction. Is that feasible?
So if the attendees, they should be able to raise their hands. So there should be a button next to their name where they can raise their hand if they would like to speak, and then I can unmute them.
That would be great because I can't see the
Yep.
chat and my screen at the same time.
Sure. So
my question is, what do you see here? And then I would like some thoughts on what people see.
okay. So Fatima would like to speak, so I'm going to allow her to talk.
Hello.
Morning.
Hi. So what I see here, it looks like a picture taken from a car passing by, and I see clouds, mountains perhaps, and a road with some water in between.
Okay. Thank you.
And there's also Elaine would also like to say something. So
I see what looks like a shore with the ocean and sand and clouds.
Okay. Thank you. Does
and
anybody
Larry,
see
I'm
the
not sure if
same
you
or
can see in the
different?
chat. There's also a few people that are typing in there. Lisa Rossman Murphy and Sandra have also entered into the chat.
Okay. Go ahead. You want to read it?
Sure. Lisa Rossman Murphy said, bizarre cloud formation on the horizon with a small stream in the foreground. And Sandra said, water, beach, mountains, and the horizon.
Okay, great. Anybody see anything different? Okay. So this is the same, it's a different foreground, but it's the same background. Does that help?
No.
Okay. So here's the long and short of it. This is a picture of tundra in the foreground and nothing in the background. Those mountains or clouds or other formations in the back do not exist, and neither does this. It is called a fata morgana, or superior mirage. And the classic story about this is that a British sailor looking for the Northwest Passage in the 18 teens turned back and did not explore Hudson's Bay and go deeper in, because he saw these mountains. He honored the Lord of the Admiralty, Coker, Lord Coker, by naming the mountain range after him. And he never got a commission again when it was discovered that Coker's Mountains, in fact, didn't exist. They were a mirage. So my point is that one needs to think about what one sees, and even one's own eyes don't always supply the evidence that one thinks they do. So I'm going to actually skip that. I'm going to move to a little different portion of this and then try to bring this all back. This is a map of the various wards of Cleveland showing differences in infant mortality. And then the implications of this are shown on this slide. This is from when I was in Cleveland, but that 8.5 miles gave you 24 years difference in life expectancy. Life is not fair, and the zip code of your birth matters. We've all heard that. I want to suggest some implications regarding to evidence and research. So we did a survey at Rainbow Babies and Children's Hospital. It's actually ongoing periodically. It happens annually, the local inventory of needs and knowledge. It's a cross-sectional telephone survey of a blitz sample from the General Pediatrics Clinic. 81% of those who were asked agreed. About 80% of those who agree we can reach a very high response rate. And this was a theoretical model that we were using, that the social environment can lead to stress, or social determinants of health. Unfavorable social determinants can lead to stress, which will impact parent and child health, and that the parent health is a dominant factor in child health, although of course that it's a bidirectional relationship. So I'm going to just summarize very quickly some of the findings. Among all parent-child dyads, the parent health was the biggest predictor of child health. Stress from social determinants of health reduced by about 1/3 the proportion of children who reported excellent health. When the parent health was not excellent, these were almost all mothers, but not all mothers, that risk ratio was 0.5, meaning 50%, half as many children in stress reported excellent, or parents who reported stress reported their child was in excellent health than those who are not in stress. But if the mother or the parent reported themselves in excellent health, that relationship completely went away. The risk ratio became 93%, and the confidence interval well extended beyond that. So it wasn't simply that a statistical phenomenon, there actually was a modification of the impact of stress based on the parent's health, suggesting that excellent parent health is a critical component supporting child health. And we don't know if the excellent parent health conveys resilience to their child in a potentially hostile environment, or if excellent parent health is a proxy for parents who are able to navigate the stressful environments for their children. But parent health matters for child health. So it's really not correct to think about this as simply a child health issue. It's a maternal child health issue. It's a family health issue. And if we want to think about children's health, it's not okay to isolate that. And it also reminds us that the measurement of specific subgroups may provide really important information that is completely hidden if we simply look at averages. So moving from that idea, we were motivated to think about inequity in care, and health inequity exists. We wanted measurement to make the inequity visible and to incorporate inequity into the judgment that the measurement leads to. So we suggested doing something called disparity adjusted performance measurement. I say we, this is the CAPQUAM, the Collaboration Advancing Pediatric Quality Measures, a CMS and ARC sponsored Center of Excellence for Child Health Quality. And it also, so disparity adjusted performance measurement can make equity a top line and not a secondary consideration. And then we also need to think about risk adjustment. When is assuming all else equal a dangerous starting point, and might risk adjustment be appropriate or inappropriate? Since statistical models need to reflect both the substantive questions that are asked and the underlying data structure. This is something we call the hazard of veiled injustice. This is going to be coming out in a supplement in pediatrics shortly. I say we, this is Liz Howell, who is now the chair of OBGYN at Penn, and I. And the idea here is that there is a prevalent and systemic racism. It could be other isms, but we're using the example of racism that can impact things like clinical presentation as well as outcomes. And some of it is through socioeconomic status, and some of it is more directly. And so if you adjust for race, ethnicity, or even socioeconomic status, you can hide that. But also, if you adjust for how sick the person was at clinical presentation, it fails to acknowledge that these actually are reflections of systemic racism and not simply differences. So if you want to look at how the quality of care that is presented by a given site functions, well, then maybe you'll adjust by clinical presentation. But if you want to understand how the system functions, adjusting for clinical presentation bakes in the fact that you become blind. It systematically makes you blind to these influences. And so we call that the hazard of veiled injustice. And there's a complement to that we term the pattern of systematic investment, which is that recognizes that different populations require a different level of services. So the failure to consider the increased need for services experienced by underserved populations, especially if you reimburse using average costs rather than that population's needs, creates a setup to underinvest in vulnerable populations. And the systematic nature of those reimbursement policies can have long-lasting and pernicious effects, reducing who's willing to care for them or the quality of care provided. And it's really important to carefully link your analyses to a very well-specified, well-thought-out and mindful conceptual model, and to keep your definition straight in order to promote equity. And if we don't look for these issues, we will not find them. So the hazard of, I'm going to actually skip that, just move on to the disparity adjusted performance measurement. This suggests that there are 3 plans that may perform the same, but you can actually see here, looking at poor versus not poor, they are very different. They have different compositions, and we would like to have something that adjusts measures for disparities in proportion to the observed disparities, that defines a normative approach, is statistically grounded, is a straightforward calculation, and is flexible to different circumstances. This is, I'm not going to leave this up here, we're not doing math today, but this just shows that we have it. It's actually quite simple, and that C constant means it can be adjusted to be made more or less important depending on the substantive circumstances. This is applying it to data. You can, this is reported care for meeting patient-centered medical home by Hispanic or not. And you can see that these states all seem to do the same, but they actually look very different once you adjust for the level of differences here, the disparities. This takes that further and just shows that the rank order actually would change as well based on these 3 states. The point here is, if you reported disparity adjusted performance rather than simply performance, you have a means of integrating the disparity into how you describe the overall level that the system is acting at. Again, if we don't do that, it looks like half of people in the United States are getting it. If we incorporate disparities, it goes down to about a third. You can use this across all sorts of different metrics. This has completed the AAP recommended 7 vaccine series. It goes from 70% to 67%, not huge, but you see, that these two states, Michigan and Mississippi, which have very similar overall performance, have very different adjusted performance because of the Mississippi actually has a much lower disparity than does Michigan. Our belief in the implications of this for policy and practice, the National Academy, as it used to be the IOM, considers equity a fundamental component of healthcare quality. I think thus we are obligated to incorporate disparities when assessing performance, and disparities adjusted performance offers a simple, flexible, and valid tool. Anyone wants to email me, I'm happy to provide you with information on how to calculate it. Our paper describing it is just about ready to be submitted. But it suggests that no longer should we confuse as similar two plans with similar average performances when one of them performs on an identified population.
Larry, we're going to have to wrap up if you could.
Yeah, I'm moving to the end. So it suggests that we should be rethinking our criteria for metrics in research. Do they spark innovation, novelty, provide an opportunity for learning? The portfolio of studies, this lays out the process of thinking through the project to develop a conceptual hypothesis, embedding your operational hypothesis within that, having study and measurement within that, and all of that leading to understanding. And then I'm going to close with this video.
Do you have a way to share sound?
Ah,
There's a place on Zoom to share sound. I'm not quite sure where it is, but
okay. Chris, can you help me?
So if you click on the, actually, I'm trying to see real quick. Hold on one second.
I had to look it up once.
You would have to, you'd have to go back out to Zoom again. And there should be a button at the bottom where it has the audio and video settings for you. And there should be a little arrow that should give you an option to share your computer's audio. Elaine in the, who's one of the attendees said unshare, then click the button, then reshare.
Oh, I have to unshare. Okay. Now, click which button? Share computer sound. There we go. Got it.
It started, yeah. Well.
And then once you click share computer audio, you'll just have to share your screen again. Did we
lose Larry?
I think we may have actually lost Larry.
We'll make sure speakers get their time. My apologies.
Just give it a minute to see if Larry rejoins us.
We will take time for one or two questions after. So if you want to put questions in chat or in the Q&A, we will try to grab those up. Larry just texted me, he got booted out.
Arnold, you could tell him if he clicks the link in the email that I sent yesterday, he should be
Okay.
able to rejoin it. If he's unable to rejoin though in the next couple minutes, might be worthwhile to just move along, unfortunately.
Yeah.
Thank you for your patience, everyone, as we try and work through these virtual tech difficulties.
We'll give him one more minute here.
As Arnold said, if you have any questions for Larry, you could type them into the chat box. And if he's able to rejoin us, we could field a few of those questions quickly.
I had one question which really had to do with how has the lens of COVID changed our perception of these issues of the health system and how the medical system does not work. But I suspect we could have a whole symposium on that as opposed to answering a question at the end of a talk. Okay. Well, we did start 5 minutes late, so my apologies, but we will make sure that our speakers in this session get their time again. One more minute. It's the Saturday Night Live conversation, talk amongst yourselves, except you're not together, so it's harder to talk amongst yourselves. Internet out, move on, he said. So we will do that and we'll circle back maybe during the coffee break. Larry can show us the video at the end, which looked like it was going to be funny. So given the cast. So with that, it's my pleasure to thank Larry Larry did this remotely while actually on vacation. So we're very grateful to him for making sure that he could share this with us. And we'll circle back. It's now my pleasure to introduce Dr. Sandra Chafulias from the University of Connecticut in Stores, where she's a distinguished professor of educational psychology and co-director of the Collaboratory on School and Child Health. She'll talk to you about her work, but she's done many very interesting different aspects of her career, including a blog in Psychology Today on student well-being and a lot of work as a school psychologist and administrator as well. So real on-the-ground experience. So Dr. Chafulias will be speaking to us about a wonderful topic, and you can see the title, Schools as a Hub to Integrated Support, that advance whole child well-being supports. Thank you, Dr. Chafulias.
Good morning, everyone. Can you hear me okay? I'm going to assume that's it. Yes. Okay, great. First of all, thank you very much for having me to be able to follow up on some of Larry's ideas in the beginning of his talk around particularly the issues he was talking about in implementation, because at the end of the day, for me, that's what it all comes down to. So it was a very nice introduction that Arnold gave, but maybe I should actually just start a little bit to share why I would even come up with this topic. I'm a school psychologist by training. I was a practitioner. I was a school administrator in Central New York before I became an academician and joined UConn, and started my career doing all kinds of research, the stuff that gets you tenure and promotions and all that great stuff. And then it was, and my area is really in behavioral health, social, emotional, behavioral success of kids. And I'm plugging along, doing all of that work that I thought was going to, change the world, as we all think we're going to. And then I realized, I see this model, which I'm going to show you in a little bit, and I start thinking about other things as I'm not doing other things, and I think, my gosh, we haven't done a good enough job. I haven't done a good enough job thinking about the whole, and understanding how all the parts connect together, and how a lot of it centers on schools as a primary system of care. Yes, family systems are very important and a very critical system of care, but schools really are a hub, as we know, for access and identification for a lot of mental health issues. That's where it starts, in schools. So how do we help schools be the hub that they can be to integrate supports? And I'll share with you what that means. So I should start the slideshow, huh? Okay, but then I can't see you, but that's okay. Okay, so I have 3 objectives that I'd like to cover for you today. The first is to just look at a couple of different models or ways that people are thinking about working to support students in schools, or using schools to support students. I want to provide a rationale for why it's essential to integrate efforts more purposefully, more cohesively than maybe we have historically. And then I'll share some examples of the work that we've been trying to do to do that integration. So to start, I assume that most folks that have that are here or have been around know this model that was released in 2014 called the Whole School, Whole Community, Whole Child, or the WISC model. That was an attempt to take an academic organization and a health-focused organization that was working on similar things, but in very separate ways, to approach this idea of whole child success and well-being, very separate silos, to coordinate those efforts. And so this picture represents a merging of the work that each of those entities was doing. And you can see, again, I'll just very quickly describe it for you, that the child is at the center, and child success and well-being is what we're looking for. And that happens through coordination of policy, process, and practice that integrates and improves learning and health. So it's this idea of integrating this piece, the pieces in policy in the coordination. And that's done through looking at kind of 10 different components, or 10 different evidence-based areas that we know kind of feed into that space. And then we wrap all of that around in community, because as Larry just very nicely shared with us, to think of it a one-size-fits-all approach, or this singular context doesn't matter, is actually not appropriate. So when I first saw this model, this was before we even created the collaboratory at UConn, I just said to myself, well, okay, all of my work is done down in here at the bottom, right? I'm a school psychologist, I'm a psychology researcher, so I do counseling, psychological, behavioral supports, and climate stuff. And I started thinking to myself about all these cases that I had over the years where maybe my work really could have been more synergistic and more influential in my behavior support planning and my mental health services that I was providing, if I had integrated and coordinated better with the other providers that are involved in school systems. So I love this model, and this has been the impetus for a lot of what we're working on. I think we've already covered this, so I'll just move on from here just quickly, just to say again, the key pieces to this type of a model is that it's student-centered, and this idea of needing to do collaborative work across policy, process, and practice, evidence grounded in the 10 components, or the blue circles that you see around, very ecologically based, and it's contextually flexible. So it's not assumed that everybody needs to do the exact same things around physical and safe environment, that there's got to be alignment of the efforts across the blues. But what looks different in one setting, what looks like something in one setting may be different for another. So now we're going to switch sides and do the stuff that I really knew before I saw this WISC model. And this is this idea of what we call multi-tiered systems of support. It's a prevention model for those of you that are public health folks, prevention science folks. It looks really familiar to you. The interesting part about all of this kind of prevention science or public health model translation into schools is that it wasn't applied to education, or it hadn't been applied until really the past couple of decades. We've seen growing interest and ways that schools organize the way they provide their services using this MTSS or public health, whatever. RTI is another word that you've seen it. Every state seems to have a fun way of calling it something, but I think we're converging on the idea of multi-tiered systems of support. But a way to organize the services that you provide. It started in early reading, really the big interest and growth started in early reading, and it was a big idea, a big push, or a big idea behind the idea of improving the K-2 reading core curriculum. So the things that are given to every student universally, the way that reading instruction is provided as a way to reduce the numbers of students who are not meeting reading expectations or not meeting those benchmarks, or the need for more intensive services, supplemental supports, or intensive individual supports to handle the numbers of kids. And so in the ideal prevention science framework, if we do a really good core or universal, then we should have about 80% of our students responding. And then we need to provide targeted supports like supplemental extra reading groups or extra time or dosage. And about 15% of those students should respond to those more supplemental, maybe group-based interventions. And then that leaves the most intense resources available for those who truly need it. So this model, again, for 20 years now, has been growing as a key way that schools organize the way they think about service delivery. They think about the way they identify kids and decide who needs which services. But again, it started in reading, or really more on the academic side. So I did a quick Google search just in getting ready for this presentation to share some examples of what we mean. And these are taken from different school districts or different organizations like all over that Google tells us. And what we see, or what I see, or what I would ask you if we were having a normal conversation or teaching in a normal environment here, is what do you see here? What I see is that we've grown the triangle to think about not just reading or academics, but what we've done is we've just split it in half so that we have academics and that we have behavior. And we're thinking about these things and doing the way we're organizing schools and the way we're making decisions about services. That's great. We've got two areas that we're focusing on, but they're still singular, or they're single siloed, and they're parallel work, but it's not what we call integration across the two, if that makes sense. So MTSS applied to education is shifting perspectives, going from just a single area or a domain to this idea of multiple domains, but they're parallel ways of doing work. So when we're talking about intervention integration, we can think about that in two ways. One is that we look at integration within a risk level. So as an example, maybe we could take something like trauma-informed schools as a growing space, trauma-informed interventions. So maybe we have a targeted intervention where we're employing a cognitive behavioral intervention like CBITS in schools for this small group of kids. And we know that this is a risk level. But we might combine that in a behavioral health space with some of the interventions that we're already doing to improve in schools in behavioral response, positive behavioral interventions. So it might be compared with a check-in, check-out intervention as an example. So that's an example of doubling or integrating different types of interventions within a same risk level. On the other way that we can do integration is across risk levels. And so in here, the goal is to target multiple risk levels and has potential to benefit interventions and benefit, repeated intervention exposure for students who need higher levels. An example here again is this idea of positive behavioral supports and interventions. If you know anything, if you're familiar with PBIS or school-wide PBIS, it has a very strong focus on core in the green area around setting school expectations around behavior, teaching those expectations and modeling those expectations. So those words are set up within an individual school so that everybody has a common language. And so for students who don't respond and meet the expectations that are hit at the green, when we intensify our interventions, such as adding check-in, check-out, or adding function-based intervention support plans, we're still using the same language and the same key components to our intervention, such as building positive praise and relationship spaces in there. But we get to intensify our exposure and the types of things that we're doing. So what is intervention integration? The issue, or the work that I've seen to date so far, is again really promising, in that we're trying to fuse independent strategies or programs to create a coherent strategy. And this is a quote from a good paper that I really enjoy reading. And so we have potential, if we do this integration using an MTSS type of picture, to have a synergistic effects. The problem, though, is if we go back to my earlier triangle about how we've split the silos or split domains of student functioning, is that we're not really integrating them across domains. So integration sounds really great, but how do you actually put the circle into the triangle is what I'm been focused on in my work and been thinking a lot about. And how do we help schools do that? Because we can't expect that they're going to be able to do this on their own. And that's what I'm going to share with you some examples later. So it's what we're calling IMTSS, or integrated MTSS, and a way to use the WISC model to enhance the way that we're doing the way that we're providing services in schools. MTSS is familiar to schools, they know how to do it, but I'm not sure that we know yet how to put the circle into the triangle across the different domains that I would say represent the whole child. So integrated across academic, social, emotional, physical, and behavioral. These initiatives are often kind of separate spaces and might be working parallel, but they're not in tandem and certainly not integrated. So this is a picture that we drew as an example of what we would mean by IMTSS, or integrated tiered systems of support, whole school, community, and child. And you can see right here in the middle of the spine, I guess we'll call it, or the middle section, is this idea of weaving together or braiding together across domains of student functioning. And then we took it a step further in our picture here example, so that we give the things that schools should be doing, but then attend also to how we work with communities and how we could partner with communities to truly integrate across domains, across tiers of service delivery, in supporting whole child. And usually this is when we have a conversation about this picture and somebody says, oh, you forgot this or you forgot that. And I say, well, my graphic designer told me I had to cut the words down because you can only put so many on a picture. So the things that are the programs or the strategies that you see are just examples to get you thinking about what we mean by IMTSS, that integrates school and community. So just in quick summary then, why do we integrate? We have the capacity to efficiently and simultaneously deliver broader approaches. We have the opportunity to maximize intervention exposure. We have the synergistic potential of blending evidence-based strategies and potential to also reduce the system overload, because that is the crux of what we need to do in considering or working with schools to be a hub. And just as one quick example on synergistic potential, I should have just brought this up earlier too. Like, let's take again this really great reading intervention. We've got a reading intervention that's evidence-based, it's solid, it's amazing, we put it in place. But now let's add some physical health spaces to it too, and make sure that vision screening has been done and the child has access to eyewear that they possibly need. Neither one alone is going to do what we're trying to talk about in integration, but together they will. But that requires that school nurse and the community partners to work with families to make sure that that happens, along with the great reading teacher that we've put in place. Okay, so we set out to figure out what do schools need, right? What do you need to be able to do this integrated MTSS? Because in my experience, again, even the behavioral health folks tend to be separate from the physical health folks in the building, and certainly separate from the academic health folks. So how do we put people at the table, and what do they need to get their resources put together to help you think about this in an integrated way when you're doing your service delivery? So we did a lot of focus groups and a lot of interviews around Connecticut, had some great conversations with folks, and it was a little unexpected to me as to the degree to what, somewhat unexpected as to the degree of the information they were asking about in a multimedia, easy to use way, to how do I build my knowledge about this WISC model thing? Because I knew the old coordinated school health, but not everybody in the building knew what that was or how that worked. Somewhat expected about the who, again, what is the strategy that we need to sustain implementation efforts? And what I thought was going to come out of this is, well, we just need support on the implementation parts, the how do we do it? So taking all that information together, we put it together into this Think About the Link project, which is ever evolving and growing. And I'm just going to walk you through very quickly some examples of the materials that we've got there. And then I'll stop and ask, and you can ask questions. So our Think About the Link project includes policy, practice, and process materials, because remember, the little white ring in the middle of the WISC model talks about everything hinging on the ability to coordinate policy, process, and practice. It's all three pieces in order to have sustainable implementation, sustainment of something. So we worked on this toolkit. I'm just very quickly going to show you the practice guides because I want to focus more so on the policy pieces that we did. We built these very brief evidence guides on each of the 10 domains. And by brief, I mean 4-pagers. I'll show you, and then we also did these very short videos to show you what the practices look like. Here's an example of a couple of snips from one of the briefs. So we very quickly on the first page just talked about what does this domain mean? So this is social emotional climate. It's right here. We make these little gears. We define it. We show some another paragraph of the evidence behind why this is important. And then we culled the literature and distilled everything into very simple strategies, or the high-level strategies that were considered low resource, moderate resource, and high resource demands. And then the 4th page is really resources that you can go that are free to find new information. We did these about 4 years ago. We're in the process this year of updating and redoing all of these briefs because we did them. When we set out to start the project, we didn't think we were going to be doing this, but after schools asked us for this, we put some efforts into doing this. So we're in the process of redoing these now. So stay tuned on those. The process part, again, I'm just very quickly going to bring this up because I want to get to the policy one, is the idea of the how. That's where I thought we were going to put all of our efforts, not on some of the other stuff, but it's this idea of an action planning, a blueprint for what do you need to take your service delivery and make it an integrated MTSS model. And we have case examples or things like this about what does it mean to move from siloed to integrated? And most of the school administrators we work with can relate to this. Student anxiety is an issue, right? That's, of course, this was pre-pandemic. I'm sure that we've still got student anxiety as an issue, but the #1 call that we would get to our offices is around student anxiety in schools. And so on the left side, you can see what a typical way that schools would go about setting up their service delivery is that, you know, maybe you'd have student services faculty working on a one-on-one plans. Maybe your phys ed faculty would meet to increase some focus on mental health in their plans. But the bottom line is that you would see separate budget requests or separate initiatives to address kind of the same issue. On the right-hand side, what we mean by coordinated or integrated WISC efforts would combine 5 of our little gears or 5 of those blue domains in the WISC model. And maybe we would have this overall team leader working with both faculty, because phys ed and student services should probably be working together. And then maybe phys ed student faculty work on core curriculum, so embedding a relaxation unit that goes for all students. And we include families as partners so that we're doing generalization and working together on what we're trying to teach in terms of skills and knowledge. And then we've got to bring in our school nurses, because I don't know about you, but I had one child that was one of the high flyers to the school nurse's office with tummy problems when they were not feeling so great. And so school nurses can create a great space for a surveillance protocol to identify and refer students who might need some additional help. And then we have coordinated budget requests in order to get this together. We're all on the same page and we're working toward the same goal of reducing student anxiety. So that's a very quick example of what we mean by process guides, because it's all about implementation, implementation, implementation. I was so glad that Larry brought that up in his slides, and the spaces in implementation science are going to be critical for us to be able to move this work truly to sustainable efforts in schools. And so our process guides or our planning blueprints take implementation science models, and we break it down into school-based ways and ways of thinking that basically uses what we call the 3 E's. I'm going to stop there and just move on to the policy part, because I think maybe that might be about something that folks are more interested in or maybe familiar with. So again, coordinating policy, process, and practice. We need policy because that's how we create, we buffer against the waves that come and go, right? We can have great practices, but as soon as we have leadership changes, things go if we're not codified. And we can codify by using our school policies as a critical space to do that. So how do we take the WISC model that's out there and build a tool that could be useful to schools in evaluating their school policies? And this is called the WellSat WISC that's out there. It models from, for those of you that are really familiar with the WellSat, done by my colleague Marlene Schwartz and her team at the Yukon Rudd Center, which was focused on evaluation of school wellness policies. So every school or district needs to have a school wellness policy on the books that participates in the free and reduced lunch programs. And the focus in the WellSat is on nutrition and physical education, because that's what the school wellness policy is required to do. If we wanted to expand to the WISC model, though, we've got all these other domains that need to be considered. So Marlene and I were able to partner together and take the structure of what they've done with the WellSat and build this tool called the WellSat WISC that uses the same structure as the WellSat and builds it up to, oh, I switched already, to a full WISC of that policy evaluation tool. And so if you're familiar with the WellSat, just really quickly, here's an example. You're basically looking at policies and coding them as 0, 1, or 2. You take each item. We have the WellSat WISC is built that we picked approximately the 10 most salient items within each of the domains because we needed to keep this measure reasonable. And you look and you do your coding and you get an example from there. I'll show you an example of what our reports look like in a second, but I just wanted to say you can find more information about what we've got in a static version on our website. But this year we're working to develop a web-based platform like the current WellSat is. And so hopefully we will get that out in good time so that people can use it more easily. So our Connecticut work to date, on my last 2 slides, we were able to partner very nicely with the State Department of Education and work to code approximately, I think we're at about 1/3 of the districts in Connecticut, all of their policies. Now it's important to remember that in the WellSat, you're coding only the school wellness policy and you're coding the qualities of just the school wellness policy. When we set out to do WellSat WISC, we realized we needed to look at every policy in a district because we assumed that there might be pieces that aren't in the wellness policy because they're focused mostly on nutrition and physical education. So we do something like this where we create these reports for school districts. And so nutrition had 15 items you can see here, and districts get reports to see how strong their policies were. The thing on the right is something that we just started this past year with a few smaller samples of districts where we did our policy coding and then we went in to interview different people in the district about their practices, and we looked for the alignment between their policies and practices, and then created these reports that would suggest maybe you want to strengthen your policy, maybe you want to strengthen your practice, maybe you've got gold star or green star, we made it in both. And so on, and gave them very specific feedback and direction as to what examples we were pulling from. Probably the quick summary or the better summary for all of you, though, is to look at some of the themes that we found specific to Connecticut. The first step here is that many WISC-related policies are not in district wellness policy. That makes sense, and that's not surprising to us, again, because school wellness policies are really focused on nutrition and physical health spaces. The part that Marlene, my partner in this project, is very shocked about still to this day, which I never was as a school administrator. So that's a good joke between the two of us, is that nutrition and physical activity policies sometimes are not found in the school wellness policy. And again, Marlene's work with the WellSat has focused on the school wellness policy, hadn't looked at the other policies that were out there in the books. And so she was very surprised that nutrition and physical activity would be found outside of a wellness policy. Definitely in the third bullet here, social, emotional, behavioral health, mental health policy is really present. It's strong, mostly because of a lot of state mandates that have come in, but it's very separate and completely separated from physical health and general wellness. It's not tied together in thinking about how this is all part of wellness. And let's see, the last bullet was that, again, WISC domains are rarely associated with wellness in school policy. So if we really want to have this idea of a whole child wellness or well-being, we really, and going to integrate it, there's work that we need to be doing with districts on the way they're thinking about policies and how they're interconnected, if that makes sense. So I think I'm just at time now, so I'm going to stop, and that's good because my last slide anyway is that just to say that I really think that if we're going to go from silos to systemic change, we have to first start to embrace and understand and help schools understand how the whole is bigger than the sum of its parts, because that's what's going to be needed to go to integration in this WISC model. And that's it for me. So I will stop sharing screen, I guess, or I'll just so that I can see the chat to see if there are questions. Or
yeah, Sandra, there's
a
couple questions. Well, Corey has his hand raised, so I'm going to allow him to speak first. And then there is a question that Fatima raised in the Q&A. So let me allow Corey to speak first and he can ask his question.
Sure.
Or she, I'm sorry. Corey, you are now able to speak. You just need to unmute yourself.
Hi, Corey, whenever you're there. Or we could start with the question, the written Q&A if you would like.
Yeah, why don't we do that? So Fatima put, how would differences in parental involvement, taking cultural practices into consideration affect the model? And who is responsible for addressing these differences?
So I think that's a great question. It goes back to the last two bullets that I had about why is a WISC model useful, and it's the idea of being very contextually flexible. So the components, I don't know, I guess we could have a drink and an argument or discussion about that. The components of the blue parts apply to all contexts, but what they look like or how they're defined or interpreted maybe should be contextually driven, including parent involvement, engagement in decisions, and community spaces as well. So schools should be open to being able to define things in different ways. I don't know if that helps to answer the question, but it's very similar to the work. So my primary work is in behavior assessment and school-based behavior tools for being able to quickly assess, to screen and progress monitor students in those different tiers. And it's a question that's come up around what are culturally appropriate and how do we define key behaviors that we're seeking in schools. And I say, well, we can define them as you want to define them. This is how we've defined them, but when we meet with teachers, we let them, we have them adapt them to fit their classroom. As a maybe more concrete example, is I had a teachers once who I thought they were going to tank my whole study because they said, we need to meet with you before we get started. We're not, I thought, oh my gosh, they're not going to want to do the study. And the whole conversation was around the fact that I had in there one of the definitions of behavior that students needed to raise their hand. And they said, we don't do that. We just want them to talk. We don't care. And I was like, cross it out then. It doesn't matter as an example. It's just examples that we came up with. But if that doesn't fit for your classroom, then you don't need to define it that way. Sorry, that was a digression, but do we have Corey?
Corey, we can't seem to hear you. So I don't know if your microphone is not working. It's showing that you're still muted, or maybe you don't have your microphone permissions turned on. You could also type in the chat box if you'd like. While you are doing that, Darren Anderson typed, for many school districts, wellness policy are nothing more than a sentence to satisfy the requirement. Given that COVID has created social isolation and further exposed the gap in social emotional learning, would you suggest a new requirement for wellness policies now that children are returning to school?
Well, if I were working in the federal government right now, I would do a lot of things a little differently. But yes, the short answer would be is that I wouldn't tie school wellness policy just to physical health and nutrition. I would like to see it be more integrated. And I'm hopeful, I'm excited, I guess, that there is a different state interest. So again, in Connecticut, there's acknowledgement that doing your federally mandated triennial review for your school wellness policy, so folks that don't know, every 3 years, in order to stay eligible, you're supposed to have your school policy be evaluated and then send it to the state. What happens with all of that, of course, is very different from state to state, but the project that we have started in is the way that we got into this is because the state said, yes, we agree that we'd like to see this be bigger and broader and more integrated across domains. So why don't we start with the districts that have to do their school policy evaluation anyway and get them involved in this to see if they want to do more. The good news, or I guess the positive part about it, is that we're also seeing pushes from local school boards. Social, emotional, and behavioral health right now is like the #1 space that school administrators are worrying about, that parents are worried about, that everyone is concerned about. And so there is this kind of maybe mass surge or interest in wanting to think about how do we support schools in being able to deliver these integrated services better. And a survey that we did of Connecticut administrators just heading into school opening, physical health, physical safety, safe environment did not come up as #1. Social emotional still came up as the #1 thing that keeps them up at night. So I think we have great potential to be able to think about how we can integrate together.
I have a question. Are there other questions, Chris? In the
that's all the questions that have come in the chat.
So I have a question as well, Sandra. That was a great talk. My question is, and I don't know how much attention you've paid to it sort of academically, I have a sense that this integration is done far better in a lot of other countries, for example, Scandinavia, some parts of East Asia, et cetera, you know, where really the integration of what happens with family and school to help the child is much more seamless or much more connected. Is that a misperception, or do you have any sense, are there lessons that we can learn in that way?
That's a really interesting question, and I'm not sure I have a direct answer. I'm not sure about East Asia, but certainly some of the New Zealand and Australia and some of the European countries they have a better integrated system to begin with, right? I don't know that the services that they're doing are within an MTSS model in terms of what the schools are focusing in, but their systems to connect and integrate across systems of care, I think are certainly stronger than what we have seen. I don't know if I can answer that other than that per se. We have a lot of work to do right now. You know, I did a presentation just like this even in I think it was Michigan last year, and they came up to me after with my example of working with the school nurse, and they said, we haven't had school nurses in our buildings in at least a decade. So I don't know what you're thinking about. So, that just blows my mind that I know our numbers are low, school psychologists, school nurses, the ratios are way higher than they need to be, but not to have a person at all really kind of astounded me.
That's very helpful. Thank you. Yeah, I didn't have a specific piece in mind, just a thought process.
Sure.
Really appreciate that. Are there any other questions? Are we seeing any? If not, we'll thank you very much for a really interesting, informative talk and really implementation for real. So thank you. So, and we'll move on to our next speaker before the break. And it's a real pleasure to introduce Dr. Ross Hammond. Let me just want to do one thing quickly. Good, yeah. Dr. Ross Hammond. So Dr. Hammond is the Betty Bowfinger Brown Associate Professor at Washington University and also a Senior Fellow in Economic Studies at Brookings Institution. And if I get this wrong, Dr. Hammond, please feel free to adjust. Dr. Hammond has a very impressive an extensive biography of contributions in multiple different ways. Director of the Center on Social Dynamics and Policy at Brookings, and many contributions academically to really the issue of systems approaches to child health, including in obesity and other areas as well, and the idea of interventions, which is what we're hearing a lot about. So I think I'll stop there and give you a chance to talk, Dr. Hammond, but thank you again very much for joining us.
Thank you. Thank you for inviting me. I'm pleased to be here. It looks like a great group. I will go ahead and share my screen. These kinds of approaches is essentially a policy laboratory where you can simulate lots of different approaches in a much less expensive way, both financially and in terms of human costs that are associated with real world policy experimentation.
Terrific. Anything else from this really fascinating talk? And we're going to hear more shortly. So perhaps
Great.
people are waiting to ask questions as they hear the applications from Dr. Kasman as well. I think some of my other questions also were along those lines of the applicability of the Somerset data to other locations, but perhaps that's something that Matt will also talk about. And we can.
Yep, he will. Great.
Great. I think we've come back onto time really spectacularly well. Thank you so much to all the speakers from the morning and the participants. We'll take a break now. I think we can put ourselves 5 minutes behind again. We'll come back at 11:20, so we'll have 10 minutes. When we come back, just for one moment before we start the presentation from Dr. Kasman, we will try very hard to run Dr. Kleinman's clip from Men in Black, so you can have the summary of that. So we'll work on that during the presentation, during the break as well. So thank you all. Talk to you soon. Hello, everyone. I will try to keep on time. So it's a little hard to tell, obviously, in a setting like this, whether other people are back in their seats or not. But we very much appreciate everyone being here. And I'm going to reach out just as we start now. Before we introduce Dr. Kasman, I'm going to reach out to Chris Gunning and ask if we are able to share Dr. Kleinman's parting scene to us. Do we think we can do that?
We're going to give it a shot and see.
Okay, I also have it up and I can try to.
Okay.
1,500 years ago, everybody
Is the
knew
audio coming through?
the Earth was the center of the universe. 500
Could be
years ago,
louder.
everybody knew the Earth was flat. 15 minutes ago, you knew that people were alone on this planet.
Why don't we restart? Great.
Yep.
Okay, here we go. Do you want to go full screen too? Or is it
Yep. Let's try going full screen.
So Dr. Kleinman was so good as to join us.
1,500 years ago, everybody knew the Earth was the center of the universe. 500 years ago, everybody knew the Earth was flat. And 15 minutes ago, you knew that people were alone on this planet. Imagine what you know tomorrow.
And that's it.
I think we get the message from Dr. Kleinman, which is our understanding and our knowledge changes and changes dramatically. So we very much appreciate all the speakers from this morning and the wonderful segue now from Dr. Hammond to Dr. Kasman, who is the Assistant Research Director at the Brookings Institute Center for Social Dynamics and Policy. Again, there is biographical information in the booklet that you received, so I think we will not take time away from you, Matt. If you're ready to roll, that would be great. Thanks.
Absolutely. I'll be sharing my screen now. Hopefully everyone can see this.
Not seeing anything in the chat room yet. I'll throw something out that would be, I presume, something you've thought about, which is that, you know, an obvious limitation, which is a strength in local communities, is the need for this interpersonal engagement with the diffusion out. Clearly, public health approaches have also included much more mass efforts, such as advertising and now social media contacts, et cetera. So I'm wondering, which would have in turn a different sort of both exposure to community, agents would be getting exposed, but would be more dependent rather than bumping into each other on, or, you know, meeting each other, contacts on, I presume, you know, level of personal engagement with media, or particularly level of polarity, you know, with respect to how they view it. I just wonder what, you know, what would be sort of the role of modeling, or have you thought about, you know, these sort of more mass approaches to messaging?
Yes, we have. I think I glossed over this pretty quickly, but an element of Romp and Chomp was a social media campaign. And the intervention experts took notes on who was targeted, who actually received this outreach, and what they think it did. So when I mentioned before that we incorporate these exogenous effects on knowledge and engagement, one form of exogenous effects was part of the intervention itself, was this social media outreach. So rather than knowledge and engagement changing solely as a result of people kind of, you know, interacting, bumping into each other, some people were kind of irradiated, as it were, with knowledge and engagement as a result of social media efforts and outreach. There's a role for this modeling to play prospectively. If we observe, for example, that in a community there's just one, maybe let's call them intransigent section of the community, that it's sparsely connected with other people, they're hard to reach, their knowledge and engagement just aren't changing, and they're kind of sandbagging the entire community, that's a place where you could target them specifically with something like social media outreach. And you could ask questions using the model of well, okay, how much outreach would we need to do? What impact on knowledge engagement would we need to have? What uptake would we need to have in this particular sector of the community to really affect the sort of change that we want?
Terrific. That does make a lot of sense, that you really could enhance targeting in that way. I would imagine political campaigns might be using this kind of modeling as well, particularly in this period. Weren't there Cambridge Associates or whatever it was? But,
yeah, Cambridge Analytics. I don't think they were doing agent-based modeling, but I don't think they told everyone what they were doing. So who knows?
So other questions? Yeah. There is time for a couple more questions.
Yes. Can you hear me there?
Yes.
Yes.
Okay. Well, I join those who are praising these wonderful presentations. Excellent. The question is, I know Max talked about agent-based modeling and readiness for change. Can we get some information regarding the situation in which the schools, the towns, the states are divided into areas that are clearly designed to determine winners and losers? When we come to the losers, how does the modeling work in terms of, the agent-based modeling, the readiness for change, any of these very laudable approaches to addressing, the issues before us?
Yeah. I think, and others agree with me, that agent-based models in general have a lot of potential for helping us understand and address disparities in health outcomes, disparities in education outcomes. And the reason for this is that these models embrace complexity in the ways that Ross was talking about. And one of the forms that this takes is heterogeneity. So we can look at specific outcomes for one section of the population versus another. We can model behaviors that differ according to those properties. One group of people may change their knowledge really, really quickly. Let's say it's because they receive high quality health instruction in their school, and another their knowledge might change much more slowly because they unfortunately don't have access to that, for example. So there's kind of there's an infinite variety in the ways that you can incorporate this sort of heterogeneity, as well as adaptation. There can be positive or negative feedback loops. The rich get richer, as it were, and those can are inherently included in these sorts of models. And so you can get a sense and intuition of why these sorts of disparities arise, why they're so persistent, and what can be done positively to disrupt them.
Okay, hello?
Yeah, it's okay.
Yeah, do we have an approach that you would say look at a group as large and as powerful, let's say, as the New Jersey state legislature, the beneficiaries of the high quality education in the high quality schools there? Do we have a model that addresses such a, when I say divergent, I mean geographically, who come together to make policies for the winners and losers?
Yeah, so my answer to your question is going to be kind of twofold. One, we're increasingly seeing agent-based modeling and complex adaptive systems science in general being used in public health. Where we are in public health, education, unfortunately, or fortunately, if you want to view it as an opportunity, is, I would say, maybe 10 to 15 years behind public health. So there's just not as much in the way of good, robust computational simulation modeling being done to inform educational policy. With that being said, I myself have engaged in some of it. During my doctoral training, my focus was on educational policy. And my dissertation focused on student assignment and school choice. This is in San Francisco. So I had lots and lots of high quality data on enrollment in schools there, how people made their selections, what they ended up doing, where they eventually ended up going. And I used this model to help inform the San Francisco school board's policies around student assignment. Their goal is and has been for some time. They notice that their schools, which differ in terms of quality and approach, but their schools are highly racially segregated. And have been persistently so for several decades. What can they do through policy that will potentially ameliorate that? And they came to me with this question and some potential hypothesized approaches, and I was able to adjudicate and provide some sort of insight into what might happen if they used some or all of these approaches to try to integrate their schools a little bit more.
Yeah, I see they're doing some very good work in San Francisco regarding the allocation of resources in emergency situations involving the police, trying to develop a unit to deal with psychological issues rather than just send the police. And I'm sure that a lot of your good work really has helped in this area. What I'm concerned about is that for the years, of our involvement in early care and learning, and we find that the zip code has greater long-term impact on the so-called losers. And I'm just reaching out to you, who I see, by your bio, that you've done a lot of work, affirmative action in higher ed and school choice, as you mentioned. Where is there a road toward the basic principles of the Constitution and equal justice for all? I'm trying to see how these very thoughtful approaches presented by you and the other panelists, how they apply, may I say, for lack of another word, the real world where children from the special needs district, their families, move them when they're 4 or 5 years old, if they can, which you can see. It's difficult to move into some of the other districts, providing much of the assets that you've discussed.
Yeah. So I think I'm going to opine a little bit on this, going a little bit beyond what I've found specifically quantitatively across all the different projects that I've worked on. I think there's kind of a few potential avenues and one strong caveat. So I think one of the strongest avenue is intervening early. I think I'm echoing what a couple of other people have said before, but intervening early on health, on education, on safety. These are things that can have long-lasting ripple effects through the life course. So what you do early on, can be incredibly powerful. And trying to do the same thing 10 years later in a child's life won't have the same sort of impact. Some unfortunate negative repercussions have already set in. Second, intervening early is also fortunately, I would say, politically much easier. That no one likes the thought. I hope no one likes the thought of a 1 or 2-year-old going hungry, getting sick. There's this notion, unfortunately, and it's pervasive, that older people kind of deserve what they get, but no one says that about children. So politically, it's much more possible to intervene early, even if it wasn't the case, and I think it is, that it's much more high potential. 2, I think getting people to have skin in the same game, to share institutions. This is why I look at things like school choice, trying to integrate schools by race and by class, have access to the same institutions of higher education. When people have skin in the same game, they have a different set of incentives to work together, to help one another out, to make sure resources flow, equitably. In other words, people following their own incentives, if they share skin in the same game, if they have are in the same institutions, will naturally sort of lift all boats potentially. But the big caveat is to pay attention to negative unintended consequences. One of the things that I saw, for example, in my dissertation work on student assignment, is that if you try to intervene too strongly, tell parents exactly what school they must send their kid to, if it's a school they don't want to send their kid to, and they can, as you said, they will leave. And so you end up with this sort of drain of the most affluent, most high-resourced families, potentially leaving for private school, for the suburbs, wherever. So it's important to be cognizant of the potential for policies to have these negative unintended feedbacks.
So we're going to have to move on to the panel, but I think that's a really good segue because each of our panelists, I think, is very much involved in issues around equity in different ways. So I want to thank you very much, Dr. Kasman. And if we were in person now, we'd all sort of stand up while chairs were being moved. We have a set of chairs up at the front of the room in our room at the Institute for Food Nutrition and Health. So we can't do that. So while I introduce our panelists, if anyone wants to stand up and stretch, feel free to. And that'll actually be a good way to segue in to introduce panelists. Again, there are really extensive biographies in the symposium booklet that Mara had put together. So I won't go into detail, but we will have each panelist talk for 10, 12 minutes or so about their particular area of interest and how they're working in the community to bridge the different systems and to really make life better for children. I'm going to start in the reverse order of what's on the sheet. So Dr. Darren Anderson is the program director of the New Jersey Partnership for Healthy Kids and executive director of the New Jersey YMCA State Alliance. Again, his background, educational background is listed, but is very impressive and has done lots of great work in applied exercise and then bringing this into the community, which he's doing really day to day now. Cecilia Zalkind is the president and CEO of Advocates for Children in New Jersey, which has worked on so many different levels to make children's lives better, both on the ground and in the political arena as well, in the advocacy role. And again, her background is listed, but she has just tremendous experience in these different levels and systems. So we'll hear from Cecilia. And then David Harris, who just asked these wonderful questions, who is, let's see, I want to get this right, the founder and executive director of the Greater New Brunswick Daycare Council, and has been deeply involved in early childhood care and learning, childhood services for several decades now, as you told us last night, and really shaping youth in New Brunswick in such a positive way. He's also been on the Rutgers University Board of Governors and the Board of Trustees as well, was the chair of the Board of Trustees, and is a child of Rutgers and of New Brunswick in so many ways. So I'm going to ask Dr. Anderson to start with sort of a description of what your interests are in your organization, and then we'll go through to Dr. Zalkind and Mr. Harris as well, and then we'll come back and have real panel discussion and take questions. Is that okay?
That's excellent.
Okay.
Sounds like a plan to me.
Yeah, so Dr. Anderson.
Well, thank you, Dr. Rapson, and thank you for the invitation. And I've had the pleasure of working with several of you before. And Dr. Hammond, you know, we took a national team from the YMCA and worked at your social systems laboratory, looking at complex and convoluted ways that the YMCAs should be doing more at the community level with our several programming, with our business model, but more importantly, with one of our pillars, which is called social responsibility. You know, I will quickly just give an overview of what we're doing here in New Jersey. I am the executive director, CEO of the New Jersey YMCA State Alliance. I represent, excuse me, 31 YMCAs across the state. Collectively, we are in all 21 counties. We are the largest provider of childcare throughout the state, with roughly about 415 licensed centers from early childcare, preschool, and as well as school age. And given the fact that COVID has wreaked havoc in our communities, we're also providing what we call virtual or remote learning school-age childcare to be able to assist children while their parents are working. So the YMCA is a human services organization, and many times, many of our constituency don't realize that. They think we're just a swimming gym or some place where you can get your physical activity, and by all means, we are. Our wellness center happens to just be one aspect of what the YMCA does. The YMCA, since COVID had really taken us by storm, has really pivoted our facilities because of due to executive order. Many of our wellness centers were shut down, but that does not mean our YMCAs were closed. Our Ys continue to do marvelous work throughout the state. We first began by working with SEAL and ACNJ and working with the New Jersey Hospital Association. And we had to provide emergency child care for those that were frontline workers, essential workers, and those that needed to report because they had a significant role in society. And we began that by providing about between 300 to 400 children in emergency child care. We were doing all of this as we were trying to understand COVID, just like all of you who are trying to understand COVID. How do we keep our staff safe? How do we socially distance? How do we wear masks? How do we disinfect? What are we going to get the resources to be able to do so while we're still providing this dire need? And while we were transitioning into this emergency child care, at the same time, the YMCA underwent unfortunately, a significant work workforce decrease. We laid off between 80 to 90% of our staff. And many of our staff that works with the YMCA was also receiving childcare because that's one of the perks of working with the YMCA. And also we began to financially hemorrhage, that the resources that once was coming in was not. And then we started getting more and more phone calls from the community, the needs from the community, feeding programs, meal programs was needed. We had children that was part of our Mickey Vento population that was not being served. Even though they attended school in a particular school district, they may have lived outside of that school district because they were either living in a motel or a hotel, or may have to, was displaced with a relative. So as children were being fed through the National School and Lunch Program, which now become a grab and go, these children were being left off. And then as we reached out to these children, and we had estimated between 9,000 to 12,000, but we know we've concentrated our efforts in the city of Trenton. We had about 1,200 children that were not being served at the level that they should have been. So we quickly pivoted. We worked direct with our capital area YMCA, and we began to provide meals to the children. But also we recognized there was another issue, that many of the children didn't have basic needs. They didn't have a clothing that they needed. They didn't have toothbrush, toothpaste. And so I have to share this reality with you, because this is what happens at the community level when you have an unprecedented pandemic and we're not collaborating at the right level, either because of bureaucracy or simply because it's not a priority for those that are in power. Now, we'll say here in New Jersey, I'm not sure that all of my panelists would agree that I do like the response of the state government in terms of the support regarding subsidies for childcare. The way that they were able to step up to provide additional services for our frontline workers and for our essential personnel, but also the way that the commissioners really stepped up and say, we have to make sure that the most vulnerable in our state are taken care of. And through our advocacy, through Mr. Harris and SEAL and their organizations, they do not bite their tongue. So if we need to advocate on behalf of our children, we do so. And so as we provided emergency child care and feeding programs, at that particular time, we had to open up summer camp. Families we have to return back to work. This was about 2.5 months during the pandemic. Summer camp was one of those areas where the governor was still very hesitant, because he did not necessarily know if summer camp would become this breeding ground for asymptomatic carriers and children. We didn't have that answer either as a YMCA, so we actually reached out to Dr. Kleiman and Dr. Richard Porwancher to help us to kind of conduct a 6-week study. The study did not come off the ground because the resources were not available, but we really appreciated the response of Rutgers, but they also appreciated that the YMCA, being the largest child care provider, we had this cohort of children that we did not necessarily know if they were are our practices mitigating risk. We knew that because we have to follow the CDC guidelines, but also we didn't necessarily know what we did not know. And the good thing is that after summer camp ended, we received one report of an infection, and that happened to be a staff member who was not socially distancing during his personal time on the weekend. So with that said, we continue to provide virtual programming, fitness programming. We have many children. We serve typically during the summer months, we serve close to 40,000 children. But during this particular period, we only served about a little bit over 6,000, 20%. So the rest of the children were at home or maybe with a loved one. And our other concern was regarding social isolation and social emotional learning. I know many have mentioned that today. And we have a program with Sanford Harmony that we provide social emotional learning as part of before and after care services, which we typically serve anywhere between 25,000 a year. And those children, once again, we were probably less than 5%, but we did provide the platform virtually so children could have some way to stay connected with one another and that they can continue to receive this service. So regarding the emergency childcare, the feeding programs, and our virtual activity for social emotional learning, our virtual fitness classes, and wellness classes, and socially reaching out to our senior population who typically comes to the YMCA, not just for the treadmill, but many times for coffee. And they sit down and they actually communicate with one another because they want to have a place where they feel connected. Well, we can no longer provide coffee. Many of those normalcies that we had are no longer in place. So we had to do something different. We had to pivot, and we had to reach out to those seniors to make sure they had their needs being met, but also making sure that the needs of their families to meet their needs were also being met. So I just kind of wanted to provide a quick overview of kind of how the YMCA responded during this particular time. And if there's any particular questions about our childcare program and throughout the state, I'm here to answer those questions.
Terrific. Thank you very much, Darren. And we will open up for more of a general discussion in a few moments after we hear from everyone. I'll turn now to Ms. Zalkin. Seal, would you like to talk for a moment, a few minutes?
Thank you very much. And it's really an honor to be on this panel with David and Darren, who I've known for a long time. In fact, Darren is on the ACNJ Board of Trustees. Advocates for Children of New Jersey is a statewide child advocacy organization located in Newark. We were incorporated in 1978, so we've had a pretty long history in advocating for children. And thinking about the topic of this symposium, we started with a focus exclusively on children and the child welfare and juvenile justice system. Child welfare defined as child abuse and neglect, foster care, placement, and adoption. And it wasn't too long in our existence that we discovered you cannot focus on one aspect of a child's life without focusing on the rest, and without also considering the child's family, immediate and broader family. So over the years, our agenda has grown to continue our work in child welfare and juvenile justice, to develop a fairly extensive presence in early care and education, starting with advocacy around the state-funded preschool through the Abbott versus Burke decision, and more recently, our focus on child care, and now a campaign we have looking at children from prenatal to 3, which I'll talk about in a minute. We're also deeply involved in the creation of the New Jersey Child Health Insurance Program, Family Care, and have stayed active in that to ensure not only that children have access to health insurance, and New Jersey has made enormous progress in that area, but to make sure that that access actually provides healthcare, and healthcare that is quality. We have worked in the area of lead poisoning prevention. That's been a long time campaign for us, and one that still continues. And more recently, in a campaign to expand access to school breakfast for more eligible children in New Jersey. A highly successful campaign that really improved what was a dismal record in New Jersey in terms of ensuring that eligible children receive school breakfast. Our mission is around opportunity. Our goal is to give every child a chance to grow up safe, healthy, and educated. And I think in more recent years, we've spent a lot of attention to the early years and how those investments at the early point in a child's life are more effective and pay off very well in the future in terms of reduced costs, which leads me to our current campaign. Our Think Babies campaign is an agenda to support the healthy growth and development of children prenatal to age 3. I'm not going to go into details of how this campaign evolved because it started with a small focus on high quality early care and education, childcare for children under the age of 3, and then grew to include how do we support families effectively and how do we ensure a healthy start. We have a very ambitious agenda, which is to increase access to high quality care and education for 25% more children birth to 3 living in families with low income. Right now, there are 109,000 children in New Jersey under age 3 who are considered to live in families with low income. And our target to increase services is 27,000 more children by the end of 2023. This goal was set in March early March. And the pandemic has certainly had an impact on how we are proceeding. That agenda includes improving access to high quality childcare, because for our youngest children, I'm looking at David, who knows this better than I do, for our youngest children, that is the early education experience. To look at how we support families effectively through evidence-based home visitation, health, including mental health services or developmental supports for our youngest children, as well as looking at maternal and infant health. And I think, our First Lady, through her Nurture NJ effort, has really focused on the disproportionate impact on women of color in terms of pregnancy, delivery, and infant mortality as well. For me, I think this agenda has brought the systems issue together in a different way. We've always focused on how do you coordinate systems more effectively. Our state service system, like every other state, is really not designed to be easy for families. We operate in a lot of silos, but I've come to understand that when we talk about a systems approach, we're not just talking about state services. We're not just talking about health narrowly defined. This is a broad system. It is everything that impacts on a child and family's health, and it depends on relationships, probably more than systems. And Darren, I'm really happy you talked about the impact of COVID, because it's been an incredible 7 months. And I think thinking about the topic of this symposium, the impact on children and families, especially vulnerable children and families, I think has been devastating. And I think we cannot even anticipate what the long-term consequences are going to be. But at the same time, it's been very interesting to see how our systems have had to step up and work differently. So policies in childcare, for example, which we've advocated for years, specifically paying programs, not on attendance, but on enrollment, the state implemented virtually overnight with the goal of sustaining those programs that were ordered closed by the governor's office. The creation of emergency care came with higher eligibility for families, higher rates for childcare programs. Again, it really created, to me, what should be our childcare system, but it came out of an emergency. Looking at our home visitation program. And Darren, I think probably the most dramatic issues that emerged out of the pandemic was the incredible food insecurity. So we saw our home visitation system not able to do what was charged to do, but stepping up to make sure that families were connected to food and that families were connected to other services. So, and now more recently, the whole issue of how schools are reopening and the impact on families in regard to childcare has made the schools and the childcare system, I'm not gonna say work together better, because I don't think we're there yet, but be aware of their interlocking, their interconnection. So I think there's some lessons learned in the pandemic as we talk about a systems approach that does provide some examples of what we can and should be doing. Now, I'll stop there and happy to answer questions. Looking forward to hear from David.
Thank you so much. That really, Seal, that really hit actually one of my questions further about the COVID impacts, and we'll talk about that more later. Mr. Harris, David, would be delightful to hear the wonderful work that you've done over the years, but also the challenges that you've faced, both in terms of the work in the New Brunswick community and sort of more generally with childcare and with the equity issues that you've began to address in questions as well.
Well, thank you so much, Dr. Robson. You and Larry are to be commended for bringing these scholars together, myself excluded from that latter part. This has been extraordinary. And for all the years, I really appreciate the opportunity to say thank you to Darren Anderson, because on our difficult days when we needed summer programs for our children to learn to swim, it was the YMCA that provided us support and never asked for a nickel. child care programs in the great state of New Jersey without Seals Elkine and advocates for children of New Jersey would be on the intensive care list. Seal has been an extraordinary leader in looking out for the most vulnerable women and children in our great state. So thank you for this opportunity to be able to share with you, and thanks, some people for our tremendous help. We got into the business when care for children outside the home was a communist conspiracy. We were supposed to be working on, as our critics called us, the Chinese model. Now here's China again being blamed for something else. But 69, 70, we began here. And for all those 50 years, we always had, when things went wrong or unexpected issues, problems with anything, we could always call on the local international leader in the pharmaceuticals, consumer products, Johnson & Johnson. The last 2 years ago, our wonderful slate roof on our historic property here decided it didn't want to work. And a couple phone calls down the street, Johnson & Johnson provided over 6 figures to address the issue, as they have each and every year. So we're very pleased today to be able to talk about where we've come, and to kind of try to interact with the wonderful leaders, intellects like yourself and Larry Kleinman. But I loved Dr. Theophilus, what she had to say about a whole set of issues, the whole child well-being, schools being the primary system of care. And we know from our experience here from 6:30 in the morning till 7 at night that the parents are relying on us for that evening meal. Should that ever happen in America? Should a child care center provide 450 meals a day? Yes, that's great. But to find that the parents set their time to pick up after the supper meal is served, to make sure. And it is very distracting for us in terms of our beliefs in our great country, that our children here could be outside of the zone of protection, outside of the dreams and aspirations of all the great thinkers of America. For you, Dr. Robson, to have put together, along with Larry, this wonderful set of presenters is extraordinary. For one little day, for us to come and interact with the intellectuals who are out there and have to try to have a meeting with those who are carrying on the practical efforts. Our children need real pediatricians. look at them individually, who will take some time, and we would have fewer physical exam reports checked off, a normal child, everything's fine, and a 3-year-old not having spoken a word that we could recognize. How could that happen? How could the doctor pass on normal child? So we go forward here. We continue to search for the parents, the deceased parents of Dr. Larry Kleiman, who in this town forced the town to build the high school on the border with North Brunswick so the school would remain integrated. This was many years ago in the 60s. Who put up their hand and said, who will stand up for these people? They said, I will. And they voted with all their influence. We will never forget Gertrude and Milton Kleinman for the work that they've done for the children who did not have the great opportunity. Sandra, we'll never forget you today discussing the inexplicable or relationship. It's not inexplicable, but it is closely tied together of parent well-being and child well-being. Thank you, Sandra. Thank you for that. It returns us to the basic foundations of the family, and we deeply appreciate that. Whole school, whole child, whole community. My goodness. We're so busy in our little programs here, working in the kitchen, unplugging toilets, running the Costco and Restaurant Depot. Oh, the milkman quit. He doesn't want to come anymore because he said that New Brunswick is an area where the virus is gonna go crazy. So you gotta go to Costco on your own to get your milk. The point is this: the great, hard-working women who trust us, the mothers who bring their babies to us. And I know what that look means when they turn to say goodbye. Take good care of my baby. I trust you, but take care of my baby. And when you see that look and you realize what they mean. So for having had the opportunity for 50 years, as I'm approaching my 80th birthday, we are deeply appreciative. We realize you cannot be a good teacher unless you're a good learner, willing to look back at the values that you hold as true. Do you believe that children can be seen or should be seen and not heard? Well, maybe your graduate education didn't work you in the right direction. Dr. Rapson, obviously, we could go on for many, many hours, mostly of appreciation. When a parent hands you a 6-week-old child and they say, thank you, Mr. Oh, please don't thank me. Thank you for that level of trust that somehow my grandmother said would be available to me if I did what she told me. Thank you for that. And we look forward to continuing to serve this community And the parents, mainly now who are from the poor state in Mexico, from Oaxaca, we love them. We don't care the documentation, whatever. The good Lord placed us in this position. We accept it. We seek further opportunity and responsibility. Thank you.
Thank you very much, Mr. Harris, for that very thoughtful, deeply moving image and view of what it really means to do what you do and what your center does every day. And the images of the mothers are really so vibrant and real. The floor is open for questions for the panelists. We have a few questions that we thought about ahead of time that you each might want to address from your own perspectives. And unless I see other questions, we can start with those. So one of them really is very topical right now, but I wonder of the panelists if someone would like to discuss really what are some of the most important barriers, real systemic barriers to equity in children's health. You know, how do we get to a more equitable scenario where we're really taking care of all children have the same opportunities for health care and for growing up in a healthy environment and growing up with the sort of maximal well-being that they can. What are the sort of biggest barriers? I know Seal talked about some of the changes that have happened with COVID-19, but what do you see, all of you, as, and anyone can start, as barriers that we all should be addressing?
Well, I'll start and then kick it over to those that are much more seasoned in this space than myself. I would say four challenges from my perspective. Number one, quality childcare is always a challenge, and ensuring that reimbursement rates allow licensed childcare centers to continue to thrive, but also attend to the health of the childcare provider. One of the demographics in this state that continues to be mind-boggling is the health of our child care providers. So we need to make sure that we are earmarking and subsidizing or doing whatever we can to ensure that they have access to health care and quality care themselves. Our food system across the state, you know, I think by looking at our state food system, we need to regionalize our food systems. You know, there's so much bureaucracy that's engaged there, but what happens is families fall between the gaps. And we have those that are in need of food and other essential items that are simply been missed out. So if there's an opportunity to begin to connect local families to local farmers, and I'm not trying to push out the distributors, but to have some way that we can have efficacy and efficiency. The digital divide is huge right now. It is huge. We have families that do not have broadband access. And if they do have a hotspot, they may be challenged to getting online. So right now, many of our children, especially our urban children, are at a disadvantage because of the virtual learning is not necessarily meeting their needs. So I'm hoping that as schools begin to open back up safely, and because of what has been missed at the beginning of this year and from last year, somehow, some way we have to work together collectively, especially on the education front, to try to make up for lost time. And lastly, housing. You know, YMCA, we have about almost 1,400 low income or transitional emergency housing. But there was an article that was written this week from USA Today that's talking about racism and discrimination regarding housing that contributed to this massive exposure of marginalized communities and families regarding COVID. And I can put it in the chat if others are interested in reading the article.
Please do add it to the chat. Go ahead, Seal. It looks like you're.
Well, I agree completely with everything that Darren outlined. I think those are clear obstacles when you're looking at the overall health and well-being of children, parents, and actually families. I guess I would look at some of the cross-cutting barriers and things like access. New Jersey, certainly compared to other states, has a system of services that in some ways is more generous. but that's not enough. Do families have access to that? And what are some of the reasons why or why not? I think, access depends on eligibility. There's lots and lots of confusion and conflict and who's eligible for what. But I mean more than that. I think it's the more inherent issues around how families know about services, how they are helped to receive services, how they are welcome, and actually stepping back, how they're engaged in designing those services and designing access. Darren talked about quality. I think that's an issue. It's not enough to provide services. They have to be high quality services if we really want to achieve equity. I think those to me have always been the major barriers to creating a system of care for children and families.
Thank you. David, do you have any
Yeah,
specific comments, please?
yes, we do. I agree with the comments of Seal and Darren. And what I feel that we need even more are public officials who will take risks on behalf of the most vulnerable children and families. There is clear information that children growing up in the midst of poverty and then going to school with other poor children is not in their best interest. The legislature has the power and the resources if they would only make it a priority for high quality integrated education, not just on the preschool level, but all the way through 12. We need a big answer. This governor has worked hard. He's supported us in our most difficult times in childcare. Now he's proven himself. We need him to take a big risk, do something big. And it's like opening up the opportunity for children from the special needs district to go to school beyond their zip code, to assist the children in suburbia in understanding that skin color, the Spanish accent doesn't determine negative future behavior. We need these children to get out of the prisons and jails they find themselves in, called public schools, and they're only locked there because they cannot afford to move out of special needs districts.
Arnold, can I add a
Please.
comment? So listening to David, it made me think about work we did not so long ago, maybe 4 or 5 years ago, to examine issues behind chronic absenteeism. Looking across the state, but more looking at individual school districts, chronic absenteeism rates are very high. So we took a data approach to this and wanted to publish a report on schools with high levels of chronic absenteeism. But we decided that we really needed to hear the story behind that data. We're located in Newark, and we worked in Newark to do focus groups with school administrators, preschool teachers, as well as parents, and later on high school students. And I have to say, to me, I went into those focus groups, the first focus group with parents, thinking, what's the issue? How hard is it to get your child to school? Well, what a naive and insulting thought that was. Because as we listened to the parents, to me, it was like opening Pandora's box. And they talked about things like instability in housing, where you could live in a place for a short period of time. Something happened, you had to move, your child's school changed. Talked about safety in the community. Things like, I have to work before school starts. Who's going to walk my child to school? Or I have another child who's sick. I keep everybody home because I don't know anybody in my neighborhood to help my child get to school. Health issues, asthma, the impact of asthma on school attendance, not only for the individual child, but for the rest of the children in the family. Listening to students at Westside High School talk about safety issues, walking to school. It was really an incredible lesson for me in terms of what impacts on that, what seemed to me to be a simple getting my child to school. All those systems that have to be in support of that child and family for that basic thing to happen.
Thank you. That does bring that systems perspective again. It really is from all these different angles. It's so complex, and the efforts that you all are undertaking are so important and so passionate in terms of really making things better. Are there any other questions? We'd have time. We started a little late in the session. There is one in question and answer from the Monday campaigns. What are effective ways to reach these families with educational materials from public health nonprofits? Any thoughts?
Well, I thought our experts really answered the question in a sense that of the inextricable relationship between the school and community, and how we can put more of those services in an affordable way into the schools, and parents will not have to take off a day work where they're not paid in order for their children to have a well baby visit with their pediatrician, who would under these circumstances would be in the schools.
Thank you. Other thoughts? I'm going to follow up with one other question that might be a good one for us to close on for this panel, but for all three of you. What thoughts might you have about how Rutgers and our New Jersey Healthy Kids Initiative in particular, but Rutgers in general, might productively cultivate community interactions and engagement, both to enhance understanding of how the systems determine child health, how all these different systems determine it, but also to really help affect positive change? Or there's sort of ideas about it. It's always complex how a university interacts with community. The students come and go. You know, the goal, you know, we've heard often the goal is not to use the community just as a laboratory and then to disappear. But so what, do you have any thoughts that you could share about how to make this sort of interaction work potentially more effectively?
No, I do, Dr. Rabson, and for many years, and maybe even up to this date, we feel like the gold standard has always been community-based participatory research or practice-based work. But I think we need to get back to authentic engagement at the community level, which simply means there's a community spectrum by, community origination, community endorsement, early conversation. Many times what happened with institutions of learning, of higher ed, is that they may pursue a grant opportunity that would allow you to have a presence in the community without even inviting someone from the community to be at the table with you, and to have the power to negotiate how much of those resources get dispersed into the community. And that's why, and many times, is that we do not view those in the communities as the scholars that they are. So we're going to work with residents. We need to start to corner them as community scholars. Who knows those communities better than those that's lived there, that's worked there, that's toiled there, that raised their children there, that know the historical perspective of those communities. And many times we come in with our data and our credentials and we say, well, this is the problem with your community. These are the delinquencies, and they're looking at you sideways because they're saying, we don't see that as a delinquency in our community. These are the issues that we're facing. So when we started our work almost 8 years ago, and Mr. Harris remembers this very well with our childhood obesity work with the Robert Wood Johnson Foundation, is that we went to the communities and said, look at the data. You have an issue of obesity, but all the families that we surveyed, over 1,800 households who provided heights and weights, and we knew that the BMIs were elevated, they said to us, there's no obesity issue in my home. There may be one in the community, but not in our home. So there was a disconnect. So I would like to implore our academic colleagues, and I guess I'm a recovering academic. I've never been in an institution, but I'm still adjunct, is for us to work with community members early in the process so they can use their voice, empower themselves to be part of the solution rather than being an afterthought.
Right. I would agree with that, Darren. I think you're exactly right. I think, Rutgers has done, I think, something important through the Healthy Kids Initiative, which is to really broaden the discussion. I think it's come with an awareness in talking about health, that we're talking about a broad definition of health. And I think that's been valuable. I mean, I look back at my own advocacy, that has certainly expanded my thinking. But in terms of working with, supporting the community, I just summarized what Darren said, 2 things. 1, listen, not go with the assumption, well, 3 things. I'm going to add 1 more thing. To be in a position of listening to what the needs of the community are. And 2, I think to take a positive, strength-based rather than a negative approach. That certainly has been an issue in the child welfare system. And I've learned that is, and this is speaking personally, that is the place to start. It's not to look at the deficits of a community, but the strengths of that community. And 3rd, I think that you really have to support people who participate. Those of us, I'll talk about myself, I'm paid to advocate. I'm not a volunteer. It's my job. But we want to engage parents in advocacy. We want to hear from them. We want them to advocate. They're certainly more powerful advocates than we are. We have to pay them to do that. They have to be supported, whether that means providing the means for them, like childcare and transportation, or a stipend to get them to participate. I think we have to value and respect their involvement.
Their interaction.
I agree with that 100%. Stipends and some level of, I wouldn't necessarily call it incentive, but it should be that they may be considered a consultant to the project and that they are reimbursed for them for that time.
Very specific, helpful, thoughtful comments that we need to take to heart, definitely. Are there any other questions from anyone? We are just at time, given that we started a couple minutes late here, 5 minutes late. I think this has been a wonderful panel. The both panel and perception, the passion and the perception of each of you really cuts so deeply and has so much to bring to the conversations that we're having now, but the conversations that we must have in the future. So I'm deeply grateful to all of you for participating, and on behalf of our audience as well, we thank you. I'm trying to see if there are any other comments. Thank you for sharing that link, Darren. I really appreciate that very much. For those in the audience, you'll see in the chat the link to the USA Today, I believe. Again, I think we will wrap it up with no other questions. And thanks again. And we look forward to seeing everyone back for the afternoon session. I'm looking for my sheet of paper with the schedule. I believe we're running a couple minutes late. So I think we would start at exactly 1:45. Chris and Mara, does that sound about right to you?
That sounds good.
I mean,
yeah.
it's till 1:40, but 1:45 is okay.
Yeah, we're 5 minutes behind now. So if that's okay for the afternoon speakers, it's 1:03 now. So that gives you just about 40 minutes to grab something quick to eat, hopefully nutritious and healthy as well. And hopefully you'll be able to actually eat instead of spending the whole time catching up on emails that came in during the morning. So thank you all. Thank you to the speakers from this morning. We look forward to seeing all of you again this afternoon at 1:45 with a wonderful group of speakers for the afternoon. Thank you.
See ya.
Share a video, whether you do it today, do it over the weekend. There's 15 days left in October. It'll be running through the end of the month. So please definitely follow us and share how you and your family will be engaging in Walktober. With that, I want to turn it over to my two wonderful colleagues, Dr. Erin Kamala and Dr. Peggy Palacastro. Like I said, you can read their bios. I could go on and on, talk wonderful things about both of them, but I will let them speak for themselves. So without further ado, Dr. Kamala and Dr. Palacastro.
Thanks, Chris. And I'm going to go ahead and share my screen.
Great. Okay. As Erin's setting that up, I want to welcome you back from lunch. And one thing I could be assured of is no matter how good you thought your lunch was, it probably wasn't as good as what we would have served you if you were on campus with us today. Because as Arnold mentioned in the beginning, usually this conference is catered by our wonderful eatery located right inside the Institute of Food, Nutrition and Health, which is called Harvest. So as Arnold invited all of you there, I invite you there as well once we're all back on campus. But to start out, I am Dr. Peggy Palacastro, the Director of Culinary Literacy and Nutrition Education for the New Jersey Healthy Kids Institute, and my fabulous colleague.
Hi, I'm Erin Kamalo, and I am the Program Development Administrator for the New Jersey Healthy Kids Initiative.
Great. So I think you'll find what we're talking about today pretty interesting, not only because, Erin, just go back a minute. Yeah, not only because of the programming, but also I think it speaks very much to many of the sessions that we heard this morning, when we're looking at social and emotional efficacy and development, program implementation, implementation science, and also involving community. So with that being said, just keep it there a minute, Erin. I'll let you know when to switch.
Sorry, that was a slip of the finger.
That's okay. We have all changed our lives since COVID, and the New Jersey Healthy Kids Initiative is no exception. You know, when our office's doors closed in mid-March and the world of human subject research became remote, New Jersey Healthy Kids Initiative quickly shifted our gears to maintain our programming and our research. Out of that switch, Grow, Prepare, Eat, evaluating a virtual summer food literacy program was born. So let me just start a little bit by giving you a background of how we came about this program. Back in January of this year, nope, I'll let you know when. It's okay. Back in January, we were approached by a Master's of Public Health student at Rutgers, who also is a seasoned teacher in the Newark school system for the Phillips Academy, which is a charter school, about doing her practicum and research project on childhood nutrition and some childhood areas. And then also at the same time, we were approached by an undergraduate honor student to work on a research project. So then Erin and I brainstormed on a project that would marry the research interest of both her and I, and also be a project that would support New Jersey Healthy Kids Initiative mission and goals. So the idea of the Summer Food Literacy Program was born. And originally we planned to use the Culture of Health Academy that's located in IFNH, the building where our offices are and where this conference should have been held. And we chose this area as they have a wonderful program that houses a summer camp for children. Then COVID happened. We hear that over and over. And we switched gears to a virtual program. So at this point, developing the content, that was the easy part. That was within our bailiwick. But teaching a group of children to use multiple online platforms was our challenge. And remember, we did this or started this right when remote learning and virtual learning began. So we've learned a lot since then, but bear in mind, we were the guinea pigs in the beginning. On the slide on the top right, you can see a flyer that we developed to advertise the program throughout New Jersey. So one of the benefits actually of going virtual was that we had a wider net that we spread to encourage children to participate in the program. If we had it at the IFNH located in New Brunswick, we may have only received campers that were from that immediate area. So that was one benefit to going virtual. So after we recruited 50 students, we fine-tuned the curriculum and learned a lot about virtual learning and technical issues involved. Shout out to Chris there, he's our tech expert. And we are often running to offer a virtual 6-week summer food literacy program. So a lot has been learned since that time. This was really meant for as a pilot program, so we do welcome any insights or any suggestions that you have. Next slide now, Erin. So this slide is a summary of the information we'll be covering in the next 15 minutes or so in discussing our research design. And I think this program really speaks again to the program of this morning. And so I hope you find some interest in that. We'll be discussing the background of why we studied food literacy. We'll mention our research questions we looked into answer, our methods, and our data collection instruments. And again, this was a pilot program, so we welcome any type of insight or suggestions that you may have. Next slide, Erin. So food literacy is a term that encompasses multiple dimensions. It includes planning and managing and selecting food and preparing food and eating food. So instead of just one dimension that most of nutrition programs center on, the why, what are the health benefits and why should we eat certain foods, we incorporated many elements of nutrition, food systems, and cooking skills into our program. We addressed the how to eat suggested foods or processes, and not just the why to eat certain foods. Next slide, please. This moves us on to our research questions. So we decided upon a mixed model research project in that we looked at not only qualitative data, but quantitative data as well. So for the quantitative research questions, we landed on: how does participation in a virtual food literacy summer curriculum influence 3rd through 5th grade students? That was our target audience. Knowledge about food literacy, fruit and vegetable intake, plant-based protein intake, and intake of foods with high saturated fat and sugar content. And as you can see there, the acronyms you see next to each of those questions represent the validated survey tools we use to gather the data. And then for the qualitative data, we're looking to examine how does participation in a virtual food literacy summer program change confidence and self-efficacy in food literacy. For this data collection, we used, excuse me, for this data collection, we used a Qualtrics feedback form, and we also reviewed all the transcripts of the class recordings to pick up on themes that came up during the presentation. So now I'm going to turn over to Erin, who'll discuss the rest of the process.
Thanks, Peggy. Now that we have a general idea about what the project looked like, I'm going to walk through the timeline a little bit so you can see what work has been done. As you can see here on the timeline, like Peggy mentioned, we really dove into this program right at the peak of COVID. So a lot of schools weren't quite sure what platforms they were using. So a lot of it was trial and error. We started by developing our cohort, our great team, and that team included Peggy, and her background is in behavioral nutrition. She's a registered dietitian and also holds her PhD in that specialty area. We had, as she mentioned, our Masters of Public Health student who also has a previous work experience in agriculture and farm systems, which was really helpful towards developing some of those attitudes and competencies. Our George H. Cook undergraduate scholar that Peggy mentioned, our NJHKI social media and tech expert, as well as registered dietitian Chris Gunning, who you've met today. Our extraordinaire from NJHKI, Mara, who does pretty much everything, and then myself. And previous to coming to NJHKI, I had taught in the elementary school classroom for over a decade and have my doctorate in teacher leadership. So we really had a wonderful multidisciplinary team offering a really wide variety of perspectives and insight into both food literacy as well as education and child development. So Let me go through just a little bit more. So we did our existing literature review around food literacy. And then separate from food literacy, we looked at best practices in virtual instruction. Not a lot had been written, particularly for the lower grades yet. I'm sure during this year, a large body of work will be emerging. But we had a rough idea of what has been done, what worked, what didn't work. So we started developing the research questions that Peggy reviewed with you. We worked with our master's program student to develop a curriculum, then funneled that down into some lessons, and then really work out the logistics and specific details of how we were going to run the tech with Chris and Mara. We submitted IRB in May. It was approved in June, and we were ready to kick off. While we waited on IRB approval, we tried out all the different platforms. Like I said, it was a big experiment with trial and error. We took a look at things like Class Dojo, Google Classrooms, and we finally settled on WebEx and Class Dojo because of some prior experience that our team had had with both. And we also started planning our recruitment strategy. As soon as the IRB was approved, all of us really went out to our social media outlets, both personally and professionally, using the flyer that Peggy showed you. And we really cast a large net to all across New Jersey. And I think we even had some interest out of state from connections of people seeing our flyers. From July 6th through August 13th, our students taught live lessons twice a week, once in the morning during the given day and once in the afternoon. And we are now in the stages of data analysis. So like I mentioned, twice a week over 6 weeks, our master's student and undergraduate student co-taught and moderated virtual food literacy lessons. These were live, so the students logged into WebEx and engaged with their teachers, engaged with each other. And then these were also recorded so that students who may not be able to attend either the morning session or afternoon session could also access the recordings provided by WebEx at a time that was more convenient for them. Lessons were about 30 to 40 minutes long, and they featured different aspects of food literacy, from composting to gardening to the different food groups and My Plate. The kids got to do hands-on activities that linked to their content learning, such as planting seeds, actually cooking some of the recipes they learned about, and playing games. As Peggy mentioned, we use both quantitative and qualitative assessments to collect our data. For the qualitative data, the survey that Peggy mentioned addressed changes in their culinary skills, their confidence and self-efficacy, and the level of their participant enjoyment and engagement. So really touching on some of those ideas about social emotional wellness and the aspect that it's not, when we are teaching both nutrition education and in the schools, we need to be attending to both the emotional response to health and healthy behaviors, as well as the behaviors themselves. We suggested that these forms be filled out as a parent/guardian, adult and child dyad, just so that especially the quantitative measures were filled out a bit more accurately. In addition to these formalized data collection tools, we also kept a running list of lessons learned as we were going along so that we could keep track of some of the limitations, some of the changes and revisions to future projects we would use, in conjunction to feedback live via the recordings, and some of the Class Dojo responses from the children. So we are in the process, like I mentioned, of doing our data analysis. Currently, we are finding some emerging themes coming up from the qualitative data that is also backed up by some of our quantitative data that we're still going through. The first is that we saw an increase in content knowledge, which is obviously always the goal of an education program. Specifically, the kids seem to really take an interest to plant science and growing food. This was an area that a lot of them really loved to engage in by planting their own seeds, and that really backed up some of the content that they learned about the process of seed to plant. We also saw an increased understanding of nutrition. Specifically, this had to do with learning different food groups, the recommended intake of those food groups, and how to read nutrition labels. A lot of the kids had no prior experience doing that before. They did report increased cooking skills in their qualitative data, and actually mentioned that they would have loved to do a lot more live cooking demos and to learn more sophisticated, challenging cooking skills in the future. They also demonstrated a willingness to try new flavors, foods, and ingredients. And the participants expressed increased feelings of empowerment, specifically confidence and self-efficacy in preparing healthy meals and snacks by themselves or with the support of an adult, and with being able to identify healthy choices for snacks and meals. Some other findings that we found were specific facilitators and barriers towards their learning. Some of the facilitators included the variety of activities that were hands-on and experiential. So no two lessons had the same exact format or the same exact hands-on activities. The pedagogical approaches that were used really encouraged active engagement and interaction between the students and teachers. So it wasn't a passive learning experience, and the kids really loved sharing their products, as well as taking their tablets or their laptops on tours of the gardens or their compost bins that they created at home. There are quite a few barriers, as I'm sure any of you who have been engaging in virtual learning have come across. The first was the time commitment. Some of the participants stated that the lessons were a bit too long. I would suspect that would probably be for some of the younger children, and that the program will be better condensed into something like 4 weeks, perhaps, instead of 6 weeks, especially during the summer when it can stretch out and families are doing different activities and traveling. The timing of activities, a lot of times the kids would sit and do the lesson, and then they were assigned to go do the hands-on part after the fact. And a lot of the kids wanted to do them right away, immediately after the lesson, instead of waiting for the assignment or even doing them on screen with an instructor and their peers. And then finally, the technology. Like we mentioned, our timeline was right at the peak of COVID and the explosion of virtual learning. So while we know that we were experimenting, that had kind of a negative impact on our participants. The switching between platforms, some of the tweaks that we had with the virtual, the WebEx platform, as well as creating de-identifying codes for each student, made it complicated for the children. So definitely something that we would be improving in the future. We're really excited about all of these emerging implications and findings, and we're looking forward to applying them to some current NJHKI projects. One of the big ones that we're working on right now, in addition to our data analysis, is the Horizon Foundation grant program, Culture of Health School program, where we're going to also be integrating some food literacy. And then, as Chris mentioned, we really encourage you to engage with us and follow along as NJHKI partners with Move It Mondays and the Monday campaigns for our Walktober. Thank you.
Any questions, comments?
Questions or comments? Thank you very much, Erin, Dr. Camillo, and Dr. Policastro, Erin and Peggy, for just a really great synopsis of how you took a very difficult situation and really turned it into not only an educational opportunity, but a research opportunity as well. And I think this is the kind of thing that people across the whole country are working with now to try to understand better how to do this kind of education, this critically important education, even in the face of distancing, which may be going on for a while. So thank you very much. And maybe a paradigm for future reaching out to much broader populations too.
Absolutely.
If anyone does have a question, just to reiterate what I mentioned earlier this morning, you can use the raise hand feature next to your name on the participants list, and I can unmute your mic if you have a quick question, or you can type it in the chat box.
And there's a question and answer box also. So thank you very much. I think we will stay on time then, since we're 5 minutes late just in general. We'll stay on time and move to our next speaker of the afternoon, Dr. Laura Lessard, who's an assistant professor in the Department of Behavioral Health and Nutrition at the University of Delaware. More of her biographical information is shown in the program, so I'll refer you to that. But it's a pleasure to have Dr. Lessard with us today. And she has really fascinating work that she'll be describing in terms of working in early care, as is in her title. Thank you.
Thank you. You hear me okay? Excellent. I was just joking with my husband during lunch. Are you more or less nervous when you can't see any of the audience members? So thank you so much for the invitation to be part of today. I think that I've been taking notes all day about intersections between things that have already been mentioned and things that I had planned to do. So I did move my slides around a little bit over lunch. So, you know, we've heard about the importance of starting early with building healthy habits for children. Dr. Kassman this morning made an argument that focusing on children, especially very young children like infants and toddlers, is politically feasible or more feasible because everybody loves babies. I love that sentiment, but unfortunately, that hasn't necessarily played out in terms of appropriate funding and support for the early care and education setting in the country, even before COVID. And now, unfortunately, during COVID, that has just gotten worse. So I'll talk a little bit about that later on in my comments. So what I want to do this afternoon is three things. I want to talk about how early care and education settings in the system as a whole can support child health and well-being. So I want to talk about the opportunities first. What are areas of child health and well-being, especially I'm going to talk about nutrition and physical activity that are an opportunity to improve. The second are strategies to achieve those opportunities or to address those opportunities. And then the third are mechanisms. So the strategies are great, but how do we get those strategies in place? And so I'm going to talk about policy, which was a theme of the morning, training and voluntary initiatives and how those things all work together. And as I mentioned, I'll make a little bit of a comment about COVID at the end. So first, in terms of those opportunities, so I'm really going to talk about nutrition, including breastfeeding and physical activity, but I do believe that you know, child health and well-being is bigger than those two topics. But for sake of time, I was going to talk about screen time, but I took that out. But I do think most of the approaches that I'm going to talk about are broadly applicable to other areas of child health and well-being. So I'm going to talk about that intersection of what kids need to grow and be healthy and to develop healthy habits and how those things can be improved. So if we talk about nutrition first, what's great about this is the wonderful nutrition researchers of the world. We already know what a healthy diet looks like for kids. For young kids, this is an example of what a healthy diet can look like for a 2 or 3-year-old. I have a 2-year-old myself, so I am very familiar with the eating habits here. So, you know, fruits and vegetables, healthy whole grains, limiting fats and sugars. Last year, with Robert Wood Johnson Foundation support, a very interdisciplinary group of researchers across the country got together and put forward healthy beverage recommendations for young children ages 0 to 5. And these are wonderful. If you're involved with communication of healthy habits with families, I encourage you to look into these recommendations. You know, on the right there, you can see their recommendations that children age 5 and younger not consume any sugar sweetened beverages, any diet drinks, limiting juice, and to really focus on milk and water. And that they provide a really wonderful set of evidence-based tools and guidelines for people to share with communities and families. So what about nutrition, you know, practices and nutrition behavior? So I think about two different things with young children and their health. One is having them be healthy today. What can they eat today that will help them be stronger today and have more energy today and have health development? And also, how do we set them up for long-term healthy habits? Dr. Hammond this morning mentioned the importance of early childhood experiences in later habits across the board, and research shows that's true with nutrition. So in terms of today, food preferences begin really early in life and can be very long lasting. And research shows us that repeated exposure to new or disliked foods can help, right? So I have two young children. I have a 2-year-old and a 4-year-old, and I can tell you that that you have to offer them healthy foods many, many times before they'll try it or like it. In fact, research shows you might have to offer the same food up to 12 times before a young child will even try it. And if you offer it in a positive, supportive environment, they're more likely to try it, consume it, and like it. And so we often say in this, try again with those healthy foods. And you should never say after one offering to a child that my child doesn't like so-and-so. Of course, yesterday my kids all liked bananas, and this morning they didn't. So it's a day-to-day fight with kids, and that's supported by the literature. And modeling healthy eating or modeling unhealthy eating, honestly, can strongly influence the food preferences and, again, the trying, liking, consuming for young children. So it's important to think about, again, their diet today and how to have a healthy diet, and also setting up those habits. So nutrition for babies, that's breastfeeding. The American Academy of Pediatrics recommends breastfeeding for 6 months for women that are able and make that choice. And then to introduce those complementary foods at 6 months, and to continue that till 12 months. And so I think it's important when we think about nutrition for young children to talk about breastfeeding as a component of that, and to talk about them together as I'm doing today. Okay, so then physical activity is really important, again, in these same 2 ways. Important today for kids, for healthy development, for psychosocial health, for cognitive development, for their little hearts inside their little bodies today. It's good for them today, and it's also good to build those habits. So research shows, similar to nutrition, that kids that are active in their early childhood, they're active later childhood, and they're active adults. And so we really want to begin building those habits and encouraging kids to be physically active as soon as possible. And as soon as possible, I love this picture of the little baby. The physical activity for infants, that's tummy time, supervised time in their tummies. That research shows you want to do for 30 minutes a day. So not 30 consecutive minutes. Anyone that's tried to put a baby on their tummy will say they'll never allow that, to accumulate 30 minutes in short bouts throughout the day. And conversely, to limit the time that babies spend in what I call confining equipment. So those are swings and exercisers, walkers, high chairs when babies aren't eating, cribs when they're not sleeping. Those types of devices are really antithetical to healthy physical development. That's really needed for babies to develop and to be able to crawl and walk at developmentally appropriate times. So luckily, we know what we want young children to be eating and doing in terms of movement. So how do we take that into early care and education settings? What are the strategies to apply that in ECE? So I want to stop for a second. I know today we've actually had several speakers who work and run early childhood education programs. So I should have had them jump in and do this for you. But in case you don't have young children or haven't interacted with the sector too much, I'm on to show a little bit of data. So we start on the left side here. These are children across the country that have at least one regular non-parental care arrangement. So that means they're regularly cared for by someone that isn't their parent. And it's about half of infants and toddlers, and over 70% of those 3 to 5-year-old preschool kids. So, kids are being watched by not their parents. And if you jump over to the right side of this graph here, you can see that a large portion of that care for 3 to 5-year-olds happens in a child care center. A smaller portion of toddler and infant care happens in centers. So I always talk about child care centers as like a little school, little classrooms, little desks, little chairs, little sinks. Very cute. With small groups of children, with generally 2 or more adults, shared facilities like playgrounds and common areas and things like that. So many of the things that we talk about and think about in the K-12 system can apply to the ECE space, but have not been applied to the ECE space, which is something I'll talk more about. Other families choose home-based providers. So those are we also called family childcare providers. Those are people who operate childcare businesses out of their homes. And actually, as a proportion of children in non-parental care, more kids are actually cared for in family childcare home-based programs than in centers. They're very common in a lot of areas, and they're culturally responsive. There's a lot of linguistic diversity, and other things that are in the home-based care setting. So both the centers and the home-based programs make up the space I'm talking about today. So back to the strategies, right? How to translate, how can ECE settings support nutrition, breastfeeding, and physical activity? Well, there's great existing research-based guidelines that show how that translation can take place. So I'm going to use these two as my sources. The first is the nutrition and physical activity self-assessment for childcare. People call that the knapsack. And that's actually a research-tested intervention that was developed at the University of North Carolina, Chapel Hill. And they culled the research on what are best practices for strategies in ECE related to nutrition, breastfeeding, physical activity, and screen time. And they put together this wonderful set of self-assessments that providers can use to assess their own policies and practices, and to the extent to which they align with best practices, or what more could they be doing to support nutrition, physical activity, and screen time with the children that they care for. And so I use that as a wonderful source of the evidence. And then the other are the Caring for Our Children standards. Now, that's developed by a national group, and it's not just about health, it's actually about everything that relates to ECE. So there are standards around curriculum, staff training, physical buildings, all different aspects, but they, in collaboration with the Centers for Disease Control and Prevention, put together a set of standards that relates to obesity prevention. Again, what are the strategies to implement obesity prevention in these settings? So here's some examples from those. So in terms of nutrition, you can think about the actual food and beverages that are served in these settings, and then the provider or adult behavior. So in terms of food served, one of the best practices is to follow the CACFP meal pattern. Well, what is that, you might ask? Maybe a couple of you know, should be like a little trivia question. So let me take a side note on that for a second. So that's the Child and Adult Care Food Program. It's actually something that everyone today should know a little bit about if you don't already. So the CACFP is very similar to the National School Lunch Program, but for child care, adult care, and aftercare programs. So it's a federal USDA program, just like school lunch, that offers reimbursement for meals that are served to children from low-income homes or from low-income neighborhoods. And CACFP has a meal pattern, and that's just like a fancy term for the rules they have about the types of food and the quantities of those foods that have to be served in order for a meal to count. And those rules about the meal pattern, they were changed in 2017 for the first time ever. The program had been around since 1968, and they had never updated those. They were updated to better align with the dietary guidelines for Americans and include more fruits and vegetables, more whole grains, less added sugar and saturated fat. And it was like a really wonderful watershed moment for this program to really be at the forefront of healthy nutrition for kids. So the meal pattern as it exists today is actually a really great guideline for what a healthy snack, a healthy lunch, a healthy breakfast, and a healthy supper can look like for a young child. And so the best practice back to that is for all providers to follow those meal pattern rules, whether or not they actually participate in CACFP and receive that reimbursement, which they can choose to do or not to do, but the meal pattern is best practice for that meal. And then the other strategies are around provider behavior or provider-child interaction. So not using food as a reward or a punishment, having adults sit with kids at the table and eat the same food that the children eat instead of standing at a separate table or eating something separate. So sitting with kids and eating. And I've already told you about the importance of role modeling and having kids try things in supportive environments. And so ECE settings can really move that forward. I remember when my daughter was about 2 or 3, her teacher at her center told me that she really liked lima beans. She was a lover of the lima beans that they had offered there. And I thought, wow, that's surprising, but it's amazing what children will eat when all of the children are consuming the same food and the adults are sitting there eating it too. And so that power of peer pressure in a positive way is really profound with young children. We also would like to see children have access to safe, clean drinking water in all day, inside, outside, self-service as is developmentally appropriate and possible with kids. So in terms of breastfeeding, there's a lot that ECE programs can do. And again, I encourage all of us to think about breastfeeding as nutrition for young children and think about it in the same way that we think about foods and drinks for older kids. So Caring for Our Children, says that the strategy for ECE is to encourage, to literally just tell families that they encourage and support breastfeeding. I love this middle bullet here. It says from Caring for Our Children that staff should be the mother's cheerleader. As someone who chose to breastfeed my children, I can tell you, you can never have too many cheerleaders for that particular behavior choice. And so wonderful to see them, recommending that be provided in ECE. So lastly, in terms of physical activity, there's kind of kid things and an adult thing. So I'm going to start on the left side here in terms of child activity. So strategies are requiring a particular number of minutes. So 60 minutes of physical activity for a full day is generally best practice. And to get kids outside every day, weather permitting. Maybe today is not the best day for it, but getting them outside every day. And then for those babies, remember we want to reduce or eliminate that confinement time. So to limit time seated or in confining equipment to 15 minutes. And then on the adult side, again, on the modeling side, to provide training for providers and teachers on what high quality physical activity looks like, and for teachers and caregivers to lead physical activity with kids. Research shows that it's actually great to have a balance of free play for kids and teacher-led or teacher-guided physical activity. Again, we can think about the teachers being role models for kids, and the teachers moving gets kids moving. So speaking of teachers and role modeling, and actually this is something that's been mentioned multiple times today. Dr. Kleiman mentioned, that really stuck out to me, the importance of parent health, the role of parent health in child health. He said that excellent parent health could be a buffer and have result in child health being better, even when the circumstances would normally warrant otherwise. And I wonder if the same is true for the ECE workforce and the teachers that work in ECE programs. So this has actually been an increasing focus of my work for the last 2 years, is to think about the role models. These role models, I've said that multiple times in the last 10 minutes. We're asking these teachers and these educators to model healthy eating, to model physical activity. So who are they? So this is a workforce that's over 1.3 million. That was before COVID. I'll come back to that later. They're incredibly undervalued, underpaid, and underappreciated. They make low wages. In fact, more than half are so low income that they qualify for public assistance. And a very small proportion have access to health insurance through that ECE employer. They're nearly all women. They're disproportionately women of color. So based on the demographics alone, you can imagine that we're looking at a population that's considered higher risk for chronic illness themselves. And unfortunately, the data show that out. They have high chronic disease risk and high chronic disease burden. So this is just one study. I did a review paper on this. There's a decent literature on the health status of this workforce, but one study of home-based or family childcare providers in North Carolina, 90% overweight or obese, 62% with high stress levels, less than half meeting recommendations for physical activity, sleep, and fruits and vegetables. Now, I've colored those percentages green and red because technically 2 of those are better than the national average for a comparable population, but we're asking this population to be a healthy role model for children. And so I think a strategy that needs to be included in any child-focused intervention in ECE is teacher wellness. They deserve the wellness that many of us have access through to our own employers. So that's something that I've become really, really passionate about of late. Okay, so how do we make those strategies happen? So it's great that we have them and that they're evidence-based and that they're based on what we want to see in kids, but how do we actually get them in place? So this model here, this is the CDC's spectrum of opportunities. They love to name things fun down there. Spectrum of opportunities sounds so wonderful. So this is their vision of the ways that the ECE system can be changed to support child health. And so I'll provide some additional details on some of these, but all of the circles are different things that are part of the ECE system that are opportunities to do improvement related to obesity prevention. And I put them in 3 buckets: policy, training, which includes pre-service, so before they're working, and in service, so professional development for working educators. And then the third are voluntary initiatives. And I want to talk about those 3 buckets. So the first under policy, ECE settings are highly regulated, and of course they should be. We want to protect the health and safety of children. So most programs are subject to a set of required policies and also voluntary policies that they may choose to abide by. So I'll start with licensing. So most states license childcare centers, basically all states license childcare centers. Most states license family childcare homes. I believe New Jersey registers them and doesn't license. It's a different phrase, but so those are health and safety, generally conceived as health and safety standards. And that, most people describe that as the floor of what we want to see in the ECE space. And then there's also voluntary policies. So we call one of those quality rating and improvement systems, or QRIS. And those are, we kind of think of them as like Yelp for ECE. So that's a system where providers voluntarily choose to follow additional policies and guidelines. And in exchange, they can earn a rating. In New Jersey, the program is called Grow New Jersey Kids. And in exchange for following certain rules, programs can be classified as a star level 3, 4, or 5 through that program. And I'll talk a little bit more about that later. So in terms of licensing, I'm in Delaware and I've done work in Delaware and nationally. About 2 weeks ago, the CDC released a national scorecard for ECE licensing and scored each state's licensing on whether or not they met 47 of their high impact obesity standards, many of the things I've already shared with you today. And I pulled the report for New Jersey. This is very hot off the press, it's only 2 weeks old, and you guys are doing wonderful. You can see the top bar here is back in 2010, the sort of proportion of licensing of those high impact standards that were in licensing in New Jersey, and it was a really small number. And as of last year, when they did this coding, it's a very large number. Half of the 47 the CDC says to have in licensing are in your licensing, fully supported, another third partially supported, and a very small number of the things that CDC says should be in licensing is there. You probably want to know what's in the 15%. I did, so I looked it up. So another thing, areas of opportunity to improve childcare licensing in New Jersey, requiring adults who eat with children to eat the same food or similar food to kids, and to do a little bit more work around portion sizes, which is a challenge for some programs. So that's wonderful. You're working with a really strong set of licensing. So 25 states have something great in their licensing, as New Jersey does. But unfortunately, the research shows that licensing is not enough on its own. And I think that that's something we've talked about today, is the importance of implementation. So my research really focuses on the implementation of policy in childcare. And so, what I and others have found is that, I did a study in Delaware that only 20% of our providers even knew what our physical activity licensing standard was. A recent study out of California showed that less than half of their providers were following their licensing 6 years after their licensing was changed. We did another study in Delaware looking at those confining devices that I mentioned earlier. So in this study, we actually went into programs as part of our QRIS monitoring and did all-day observations in programs and classrooms. And through that study, we found a high level of confinement of infants. 22% of the infants were contained in those devices over 30 minutes, which is a violation of our licensing standard. We have in Delaware, as you do in New Jersey, best practice on confinement. So clearly the licensing is necessary, but not sufficient to change provider behavior for a number of reasons. And training, technical assistance, and support are things that need to be part of the story, and that policy alone isn't going to get it done. When I talk about this work, I often say that these kinds of licensing changes, everyone knows they're not enforceable. Everyone knows that. The licensing monitors know it, the providers know it's not enforceable. So the only way these licensing standards are going to be implemented is with a carrot, not a stick. There's no stick, there can't be one. So I think that we have to think about how to support programs and provide the resources they need to come into compliance. So your QRIS, which is called Grow New Jersey Kids, is relatively new and has some really wonderful obesity prevention standards in it. They offer coaching on obesity prevention. They use the self-assessments that were part of the knapsack intervention, which is all really, really exceptional. They have breastfeeding in their 3-star requirements. So these are all wonderful. But again, on the implementation side, there's very low participation in your QRIS, and that's another area of community involvement, of opportunity. Make that system, make that QRIS system really great, and then increase participation in that system. And what are the ways to bring programs into a voluntary system like this so that you can provide the supports that are available? So the second bucket under the mechanism is training, and the CDC spectrum of opportunities provides a lot of opportunities for training, again, pre-service and in-service or professional development systems. So we can all brainstorm a million ways to integrate training into all of those. Pre-service training is generally accomplished in community colleges. So partnering with community colleges to offer nutrition, physical activity, health and development training for pre-service teachers, so that they know what those best practices are and are better prepared to be healthy role models for kids. In terms of technical assistance, there are many individuals and organizations that are in and out of ECE programs every day, supporting families and children and providers, providing early intervention services, providing academic help, providing mental health for children, families, providers. All of those TA providers can be health ambassadors. So in Delaware, we've worked to train those providers on some really simple nutrition, physical activity messaging that they could integrate into the work. They're already out there, they're already doing it. So they just need the tools that we can give them to provide that training. And then the third bucket are voluntary initiatives. So Farm to Preschool, which is Farm to ECE more broadly, is something that's expanding across the country for many of the same reasons that it's expanded in the school system. Farm to ECE, as with Farm to School, kids who are offered these farm fresh produce are more likely to try it, consume it, and like it. So expanding that and expanding those connections. Healthy Way to Grow is a national initiative. It's a voluntary program that offers some support for programs who want to work on nutrition, physical activity. And then again, the staff wellness. So I work with a group down at the Medical University of South Carolina who have a staff wellness intervention called Be Well, Care Well for childcare providers. It's a wonderful program, a voluntary program. Again, I think the best mechanism is to layer the policies with the training, with these voluntary initiatives. Unfortunately, research is showing us that if you just rely on voluntary initiative, it tends to exacerbate the inequities within the ECE system. The providers that are able to and know about these opportunities, able to participate and know about it, tend to be higher resource and serving higher resource children and families. So we cannot rely on voluntary alone. Unfortunately, the participation will really rise up the high quality programs and leave the lower quality programs behind. So with the last few minutes, I just want to say a couple things about ECE during COVID-19. I think that Darren mentioned during lunch, so I don't need to say, I don't want to go too far because I think he provided a really great example of what it's been like to operate programs. Many programs across the country have been operating this entire time, first to serve the families of emergency workers. And now many programs are also serving school-age children, and as Darren's programs are. So they're out there and they're serving families. Both of my kids are at a childcare center right now, so I can be here talking with you. These are some data from programs in New Jersey showing just how few children are back in these settings because families don't feel comfortable sending their children back or are not able to afford it anymore due to job losses. So the green is sort of 100% enrollment before this started. And you can see now, as of a few weeks ago, programs are really back at a fraction of the enrollment that they were at before. This is a system that was already operating with very little resources and razor thin margins. So they cannot afford to continue operating with reduced capacity enrollment, increased costs for PPE and cleaning without help. So here's some more data from New Jersey from a survey in July that 42% of the programs said that without public support, they would be in jeopardy of closing permanently. And nationally, about 40 to 50% of programs say if they don't get support, they will close permanently. And when many of us are able to return back to work full time, there may not be a childcare sector for us to return to. So I've become an advocate for programs and funding programs at the state and federal level because unfortunately, we can't care about nutrition or physical activity or child health in a program that is not operating. And so I encourage all of you to think about supporting this sector as part of our work with health. and that families have a sector, a healthy sector to return to someday. Okay, so I've shared these 3 things. I'm excited for any questions folks might have. Opportunities abound to support child health in the setting. We know what works, and we have mechanisms that we can use, policy, training, and voluntary initiatives to implement those strategies. So I think I will stop.
Fantastic. Thank you, Laura. What a great tour and journey through the world of early childhood education and how we can really have an impact to continue to improve. Are there questions? There is a comment. Did you want to, Chris, are you keeping, do you want to take a look? Looks like there's a comment.
Sure. Looks like Corey had a comment. It said about 5 to 6 years ago, New Jersey DOH and DCF worked together to implement trainings and TA to ECE settings after receiving CDC and NEMOR's grants using NAP, SACC, and CACFP guidelines.
It's quite the alphabet soup. Yeah, that's one of the wonderful things. The CDC did a series of learning collaborative, I think. 9 states across the country work with CDC funding with the Nemours Child Health Foundation. And I think that actually, and maybe it sounds like Corey knows more about this than I do, I think that some of that work resulted in your licensing standards being some of the best across the country, resulted in the integration of some of these topics in your QRIS system. So I think that that is a really wonderful thing to build from, and that you obviously have statewide buy-in for these topics, and it's just a question of providing the support for for the workforce and for settings, especially during COVID. I've been frustrated. You don't have this problem in New Jersey that we have in Delaware, but I've been frustrated that our state during COVID has completely relaxed our physical activity, screen time, and outdoor time requirements. So they don't have them right now because they think it's too hard for providers to meet those recommendations during COVID. And last week they said that providers are not allowed to do experiential nutrition education anymore because it's not safe. And none of that is science-based. So that's a Delaware problem. But I think we want to not, people are using COVID as an opportunity to step back from progress. And I have not heard any about that happening in New Jersey, but it is important. Child health, nutrition, physical activity, those are the things that promote mental health in kids and the resilience they need today to deal with the stress of COVID. So I hope that we all continue to do this work during COVID and not kind of set it aside. It may be more important now than ever.
Am I unmuted?
No, you're not. Go ahead. Stop.
Hello? Oh, you just closed me up again, Beth. Okay. Thank you for that great presentation. It was really very insightful. Can you hear me there?
Yes.
Yes, we can hear you.
Part of the sadness of New Jersey, and I can't spread it widely because I have to speak for our program here, is half of my caregivers are making the minimum wage of $11 an hour without benefits. And it's just devastating to essentially, this is an issue for the broader society, but it's a mirror as to what we think of women. The preponderance of the workers in childcare are women. And somehow we think that it's their job to take care of children and at a wage, like your literature says, makes them qualify in many cases for food stamps. This is, until we go to that issue, I think, obviously everything else you said in terms of nutrition, I love the water at all times. It's a battle though, to keep those cups available. And, you know, all the, and the outside, what I was not aware of was the 15 minutes on the infants. They should not be, could you just restate that? Yeah.
Sure. Yeah. Actually, the 15 minutes is the limit. It should be the general limit for those confining equipment. So that's a crib when they're not sleeping, a high chair when they're not eating. Often infants are put in like boppy pillows, those like U-shaped pillows. So that counts as well. So kind of anything that restricts their movement, bouncy chairs, swings. So that's all should be restricted to 15 minutes, you know, at a time. And used sparingly. And in family childcare programs, those are used more because there's one adult in the home and they may have to change another child's diaper. And what are they going to do? That's a safe place to put one baby while they're changing another baby. So it's not a never, because certainly that is safe for that baby at that moment. But those devices do have, you know, there's evidence that shows that actually that restricted movement can have negative consequences for baby's ability to have the neck muscles and arm muscles they need to be able to push up, to crawl and walk.
Well, at a certain level and for certain periods of time, we have to plead guilty for that. And it goes sometimes to the conditioning of people, of the caregivers, to be able to get up and around and stimulate the children. We do well in terms of children going outside, you know, the water and the other nutrition issues. But, oh my goodness, it was great to hear you, but there was pain there. But thank you so much.
Yeah, I know. I had done this metaphorically, the same study multiple times in multiple jurisdictions where I demonstrate that providers are not following these laws. And I've done that study probably 5 times. And a few years ago, I'm like, I'm not doing that study anymore. I'm only doing bright spotting. I don't know if anyone's familiar with that phrase, but I'm only doing studies to find best practices to help lift up, because many providers have come up with amazingly creative solutions to things. And during COVID, it's been, I know I was reading the other day that to get the kids to get really good at hand washing, they put stamps on their hands like you get at a nightclub. And they have to keep washing their hands until the stamp is gone.
Okay.
And the creativity of that, and the creativity of the sector, it's just so amazing. So I actually last year partnered with the city of Philadelphia to do some story gathering from their providers around water. And what are they doing to get kids to drink more water? And there were all these great things that they were doing, you know, putting vegetables and fruit in the water to make it look more fun, and to have like a water flavor of the week with the kids, and turn that into a lesson around healthy fruits and vegetables, and cucumber water and cilantro water, and all these different things that they did, and turning it into a game. And I think that providers have all these great ideas, and I have really turned my research to lifting up those great ideas and sharing them, because you all are very modest, but those are the suggestions that others need to hear. So.
That's lovely of you. We use, you know, we used to be committed to, you know, paper cups. Now we use so many of those, we went to plastic, you know, to our chagrin. That oh my goodness. Well,
so I just wanted to cut in real quick. We did have one more question. I'm gonna enable Fatima to ask her question. So Fatima, you can go ahead.
Hello?
We can hear you.
Oh, okay. Thank you so much for the presentation. By the way, I just want to say that you made it very easy to understand all the concerns that we might have about early childhood education. I just want to point out what you just mentioned about your feeling towards things that are happening in Delaware, and the speed at which research happens versus the policy that is implemented and the decisions that are made right away by government officials. What can you say about the discrepancies in the timing of research and policy, and what can be done to address that?
Yeah, thanks. I know it's horrible. I mean, all of us that are academics on this symposium, we know that our work takes longer to get out there than is useful in most cases. That's just a thing. And even like, I'm committed to translation of my work to practice, as you probably can tell from my presentation, and I don't even do work unless I know it can be used by somebody for something. I partner with Philly on their project because they wanted to know something, and so I don't even do that, but it's still a limit, my limit. So there's kind of what I can do on my side, to try to partner with communities. But I think COVID, if you're speaking specifically about COVID, I think what I'm seeing in Delaware is that the state is just like better safe than sorry and everything, and just like no unless we know it's safe. So I think that I don't know. I've taken to Twitter like with my state this week with all this stuff, like all these people. I used to work at the CDC, so I still know people there, and I emailed them and I'm like, give me the stuff that I need to convince my state that it's safe to do the nutrition education with kids and that hands-on practice. And so I'm trying to like feed that up to them and do that, but I think that they're really hesitant. People are really hesitant right now to try anything, and the answer is no. But I think it is important for everyone here today obviously cares about these topics, to continue to be an advocate for these things even when they're not as in the forefront. In the previous presidential administration, the first lady had this whole Let's Move initiative where it was like funded, and it was front of mind for many people, and now it's less so. So I think we have to just keep it on front of mind. And I will do my part on the research side to try to get stuff out there.
Thank you.
But we're sometimes limited with our speed. So
thank you so much.
Thank you very much. Great questions, and thank you very much, Dr. Lesser. That was really a superb presentation. Really appreciate it. And keeps bringing the importance that we're hearing here of the early childhood period. We're going to switch gears to end. We started with a pediatrician. We'll end the day with two pediatricians coming at similar and different angles and thinking about systems both at the level of the individual child, of course, the family, and the environment. We'll hear more about now from Dr. Maida Galvez. Dr. Galvez is professor in the Department of Environmental Medicine and Public Health and the Department of Pediatrics at Icahn School of Medicine at Mount Sinai, and she's the founding director of the New York State Children's Environmental Health Center. And again, she has a very distinguished and impressive list of accomplishments in the area of environment and child development. So Dr. Galvez, please.
Thank you, Dr. Robson. It's been so great to be with you all day today. I've learned so much and look forward to this conversation. Just going to take a second to share my screen. All right, here we go. So I did my residency training in the Bronx, and it was there that I saw firsthand how neighborhood shapes health. And as I was finishing my residency, Dr. Ellen Crane, who was the emergency medicine director of a level 1 trauma center in the Bronx, was the elected president of the academic pediatric APA. And she made children's environmental health her platform, even though it wasn't routinely part of her day job. And she, knowing leaders in the field like Phil Landrigan, said that we need a fellowship training program to ensure a pipeline of future leaders in the field. And they got together and got APA to sponsor this fellowship right as I was finishing, and it changed the course of my career. So happy to tell you about how events unfolded after that. I was welcomed into this larger community of practicing clinicians in the field of environmental health who found their way to this field despite the fact that there wasn't a formal training program. But I was also co-mentored by a multidisciplinary team of research scientists, all committed to thinking about how the diverse range of environmental exposures through a child's lifespan impacts their growth and development and their risk for chronic conditions. And so the founding principles of children's environmental health are that as we walk through our daily lives, we're exposed to a wide range of chemicals. And what I've appreciated about being at Mount Sinai is that environment is broadly defined. So it's everything from chemical to neighborhood to toxic stress. And what we find is that when families call us about questions related to concerns of exposures, the main outcome is the stress that they feel from not knowing what that means for their child's health. But what we've seen from the literature, including studies authored by Dr. Rosalind Wright, is that stress combined with those exposures, in terms of their associations with health outcomes. And so the founding principles are really rooted in many of the principles that our speakers have walked us through today. So kids are not little adults, their breathing zones are closer to the ground, they have age-appropriate hand-to-mouth behaviors, greater exposures pound for pound, they lack variety in their diet, immature metabolism, developing organ systems, and more years of future life. And this simple fact, kids are not little adults, is what Phil Landrigan got a committee, a diverse committee on the National Research Council to agree on when considering pesticides in the diets of infants and children. And he basically said that you couldn't use the existing standards for the 70 kilogram adult male, that they were inadequately protective. Had to think about children's unique vulnerabilities and why place them at increased risk. And that actually led to the food quality protection. And so what this training has done for me is it's expanded the concept of what it means to practice community pediatrics. And I'm going to walk you through what that means. And so what it means is that we want all pediatricians to prescribe healthy homes for families, for children who return home every day to homes that have many stressors, amongst them things like peeling paint, water damage and mold, problems with roaches and pests, and others that essentially continue to be ongoing triggers for things like asthma, but also are a source of stress. And we say that home should be a refuge for families, but for many families, it is not. And I wanted to take a moment for folks to put in the chat what they think this building is used for. See if I can't see the chat actually. Interesting.
But I can keep an eye on the chat, and if some ideas start coming in, I'll rattle off. So Carmen said a warehouse.
A warehouse. Very good. Any other thoughts?
Factory, a school.
Yes, in that order. It was a warehouse, it was a factory, and then it became a school. And it was a school in this form. And I'm going to put up another one. This one may be more familiar to you. This happens to have been in New Jersey. Does anybody know this building?
A church came in. A health center.
Not a church, not a health center. I'll give you a hint. It is directly related to the Dr. Lessard's.
Health center / house of worship.
So, so the first one is PS 51, the Bronx New School. It formerly was a lamp manufacturer and an auto mechanic. And it was, after operating as a school for many years, found to have levels of a solvent or volatile organic compound that exceeded guidelines in the workplace for adults by over 10-fold. And once those results were confirmed, this school was permanently closed. But above and beyond that, I would sort of say, take a look at that school, and that was not the initial thought that it was school. And what does it say to children in terms of how we value them and how we value our education when these are the types of buildings we're sending them to every day? And it's sort of an argument that environment makes a profound difference. The second is, and one of the things that you'll notice from that building is that there are no windows. And that actually operated as a daycare. So you may recall Kitty College back in 2006, which was formerly a mercury thermometer manufacturing company. And when that was discovered, that also was permanently closed. And it actually led to legislation that shined a light on the siting of schools in places that had standards that exceeded workplace standards. And so New Jersey actually has legislation in place that's more cutting edge than many other places in the country, where really they're only looking at lead and asbestos and not considering historical use of buildings. We want to prescribe healthy schools for all children, and COVID has shined a light on the critical importance of healthy school environments and the many gaps that exist when it comes to things as basic as ventilation. And so that PS 51 in the Bronx was relocated to this school 2 miles south. We want to prescribe nature for children, getting children outdoors and active, and making sure they have access to green spaces, but also to places for organized physical activity. And as someone who early in my career was, the research that I was doing was focused on the urban built environment and how it shaped behavior, specifically diet and physical activity. This was one of the most exciting days for us. This was in January of this year, a freezing cold day, but this was the work of a partnership that was ongoing for well over 5 years between Mount Sinai Health System, New York City Public Housing, a land trust, the Trust for Public Land, and Carver Houses Resident Association. And essentially what got done is we were able to launch the installment of this fitness zone that's accessible for those 13 years and older. And you can imagine how critical this was, having access to something like this in the time of COVID is critically important. And that's the Tenants Association, who is programming or plan to program it with a local fitness organization. So I direct the Pediatric Environmental Health Specialty Unit. We cover Federal Region 2, that's New Jersey, New York, Puerto Rico, and the US Virgin Islands. And so here's the national website. It's funded through CDC and EPA, and it's managed by the American Academy of Pediatrics. So if you have questions or concerns about environmental exposures, this is a quick reference for resources that you can go to. You can also find your local PACU, but that's us, that's Sinai. And we're really fortunate, as Dr. Robson said, that New York State is the first in the country to take that PACU model and build a similar model that's statewide. So this is the first publicly funded statewide network of children's environmental health centers in the country. And we're funded at almost the same level as the country, meaning that our funding levels we're both equally funded. It's $2 million per year in New York State and about $2 million per year for the country. And so the only way that we can even begin to think about having our reach either at the state or at the regional level is through community partnerships and capacity building. And so our partners in New York State are located at children's hospitals in Albany, Buffalo, Syracuse, Rochester, Westchester, New York City, and both Northwell and Stony Brook. And together with their community partners who are helping to really champion healthy environments for all families across New York State. And the way this got done was over 10 years of advocacy led by Dr. Phil Landrigan and leaders in the field. So the person in the center in the gray suit is Dr. Rob Amler, who's now at Westchester Medical Center, the Dean of the School of Public Health, together with our commissioner in New York State, Zucker, and other leaders in the field, including community partners, and going and meeting with key decision makers and telling the stories of the patients who are coming to us who had trouble getting answers to the questions that they had, or the clinicians who were struggling to field those same concerns in the clinical setting. And it sort of emphasizes the power of storytelling and how important it is for us in the medical and public health community to tell those stories. And so what we've done in New York State is we've taken the PACU model, which is built off a hotline model, much like this Poison Center. So families, clinicians, communities can call that hotline for information and guidance. And we've shifted it to a model where we're now actively screening families for and so it's meaningfully shifted the population that we serve, because highest risk families weren't necessarily the families that were seeking out our services. And so you see a picture at the top of Dr. Lauren Zajac, our clinical director, together with Jasmine Bhatia, who is a New Jersey PEDS resident, who is now PrevMed resident at Sinai, and medical students. And what Dr. Zajac has done is she's integrated healthy home screening into the social determinants of health screening in the general pediatrics practices at Mount Sinai. So our SDH screening now goes above and beyond housing instability and looks at the range of healthy homes concerns that our families are often faced with. And on the right, Dr. Zajac is working with a pediatric allergist immunologist to co-locate environmental counseling and screening in pediatric allergy immunology and pediatric pulmonology practices. So right after a child with moderate persistent asthma is seen by those subspecialists, they go to Dr. Erin Thanek for counseling and screening and connection to community-based resources. And so this is an example of the types of conditions that you see typically in public housing in New York City. And they've said that the maintenance costs now are projected to be $68 billion to repair the substandard maintenance and conditions that exist in NYCHA. And that's data that we have for the public housing stock. We're missing that data for private stock, quite frankly. And so this is not something that's unique to public housing. This is a problem across many forms of housing, not only in the metropolitan region. So here's what we've done. We've basically encapsulated key messages into something we call prescriptions for prevention. And I'm going to walk you through what we do with them. This is one on safer pest control. And so they're intended to screen, counsel, and refer families. And so the front of the prescription for prevention takes guidance from the American Academy of Pediatrics Pediatric Environmental Health textbook. The guidance has been reviewed by a team of experts. And the back of the resource connects families to local resources and interventions. So here's the screener that you see. It's for us, it's a red cap survey. Then once a problem's been identified, they get prescribed, the families get prescribed the prescription for prevention, and then they're referred to the Healthy Homes intervention, which for us encompass Little Sisters of Assumption Family Health Services, a longstanding community partner that has a robust environmental health program for both private and public housing, AIR NYC, and the New York City Healthy Homes program run by the Department of Health. So the way these prescriptions for prevention were developed is by a team that included PACEs in federal regions 1, 2, 3, 5, and 9, together with community engagement cores from the National Institute of Environmental Health Sciences programs in those same regions. And we now have prescriptions for preventions on a range of topics, largely healthy homes related, but we also have COVID, green cleaning, and safe disinfecting. They're being widely disseminated through our New York State network, as well as through our Region 2 PACU. So they're being applied to our hurricane recovery work in the Caribbean, specifically in Puerto Rico and the US Virgin Islands. And they're also being taken and adapted by regional PACUs and community engagement cores outside of our region. And that's something our team is able to help with if anybody's interested in taking them and specifically adapting them for use in New Jersey. When it comes to research to action, the way that we do this is by bringing in an interdisciplinary team that really is at the front line of the interventions that are needed to see the environmental change that frontline communities need. And so we work together with We Act for Environmental Justice, an environmental advocacy organization, NYCHA Housing, as you've already heard, Parsons New School of Design. They have a healthy materials lab, are really focused on making sure healthy materials are used in affordable housing and early learning. Children's Environmental Literacy Foundation, which is focused on getting environmental education into STEM curriculum and teacher training for middle schools and high schools. Local community organizers and partners, city council members, and CUNY Law School Center for Urban Environmental Reform. So you can see how this interdisciplinary team comes together, and it's essentially a think tank, if you will, to think about community concerns, innovative solutions, and how we can bring together forward the change that we all want to see. And so you've seen how, for us, bringing research to action means making the linkages between health systems, community partners, and public health agencies. That's the upper left-hand corner. Developing tools that clinicians can use to connect those dots, like prescriptions for preventions. And by clinicians, I'm really talking broadly defined: pediatricians, nurses, nurse practitioners, asthma counselors, social workers, and community-based organizations. And then at the bottom right-hand corner, you see how we're taking community science tools, developing them with public health agencies to address concerns like bus idling and truck traffic, and placing them into a survey in an open source platform, and incorporating that into the teacher training that SELF runs in their summer institute, where they work with students to collect the data, to learn about existing databases like Environmental Health Data Portal, and then use the skills that they've gained to apply novel solutions to the problems that they're seeing. So youth-powered solutions that they can use for advocacy locally. And the last is really building this network of champions in diverse fields. And I'm going to walk you through what that means. And so here is the National Institute of Environmental Health Sciences Film Fest in Durham, North Carolina. At the far left corner, you see Professor Rebecca Bratsby's, the director of the CUNY Law School Center for Environmental Reform. She developed a graphic novel with a DC Comics animator that teaches youth how to community organize around environmental justice issues. And we worked together with her to make a short film in English and Spanish so that could be more broadly disseminated into youth curriculum. And this was her premiering that film at that NIEHS Film Fest. So it's connecting people outside of our normal field and bringing them into the research community, and vice versa. It's taken me and put me in front of audiences that I don't normally speak to. So this is me at the Parsons School of Design Annual Conference, Material Health, Design Frontiers in the Built Environment, and in front of housing, architecture, and design folks at a Metropolis think tank. I'm talking about how they really are at the front line of the interventions that are so needed for families, and how with a little bit of intentionality, they can ensure that the interventions are equitably distributed to families who need it most. And this shows you how we would traditionally design our outreach and education. So on the left, you see our Mount Sinai Simple Steps to a Healthy Home Environment. And on the right, you see how Parsons School of Design takes the same information and puts it in a much cleaner, more visually appealing format. And it shows you how really using an interdisciplinary approach enhances all of our work, makes us more effective messengers. This is our our first ever Children's Environmental Health celebration. It's celebrated every year, the second Thursday of October. We were thrilled that New York State issued an official proclamation recognizing it, and we gave awards to community organizations and environmental, a toxicologist from EPA, and a parent champion. And this celebration has expanded every year. We've gotten a New York City proclamation, and we hope that New Jersey will be part of the celebration next year, and we can have a New Jersey proclamation as well. That was something we were trying to work on this year, but didn't make it to the finish line on. But we're hopeful that will happen next year. But Children's Environmental Health Network has launched this initiative, and it's really led to a groundswell of activity, and their celebration based in DC, but held virtually this year, reached 2.7 million people, both nationally and internationally. And that's really what we need to affect change, is speaking with one voice and making sure that messages about the critical importance of healthy environments for all families is heard. And so under the leadership of those community partners and advocates, specifically the Just Green Partnership led by We Act and Clean and Healthy New York, they got this piece of legislation in New York State to the finish line called the Child Safe Products Act. It took, again, well over 10 years for this to happen. You sort of think, who's against safe products for children? And apparently there were many people, and that's why it took so long. But we're thrilled that it passed, and now it's in the implementation phase. And we're so excited that they're the ones that are making sure that this is implemented in a way that makes sense and protects families. And I started with how the training opportunity really paved the way for this work for myself and the team that I work with. And that's why we so value training programs and the impact that they can have on shaping careers. So we've made an environmental health scholars program a major feature of our New York State network, except that we've broadened it so it's not limited to pediatricians. It's actually an interdisciplinary training program open to all applicants for a 1 to 2 year training. We just accepted our second cohort of scholars, and we train folks at all levels, whether they're high school students, as you see the student in the middle is a high school student that spoke at last year's Children's Environmental Health Day and brought down the house. Medical students on the training the next generation in the left-hand column, and then our first cohort of scholars in that blue right-hand column. And we really think this is one of the most important things we can do is train this next generation. And so what we want to see by doing all of this work is children's environmental health in all policies. And to get there, we need champions in a variety of fields: academic, government, public health, community, and beyond. This is what it takes to transform research to action. And storytelling is a critical component of this. And so ensuring that we train the next generation to be powerful storytellers is so important. It takes a village to do this, and these are all our partners. One of the reasons I'm so thrilled to be joining you today is whenever we talk about the New York State network, we say we hope New Jersey is next. And so we hope that New Jersey is the next state to have a statewide network of children's environment, or to ongoing conversations about how to make that. These are some additional resources for folks that will be shared in the slides, as well as texts and articles we think are really helpful. And just want to acknowledge our funding sources. But
thank you very much. Am I interrupting? You're acknowledging the funding sources. So thank you so much. Talk about storytelling. You told a beautiful story of how you personally and then the whole program grew together to be this real model of what one can do in terms of moving forward with environmental health for children and expanding that across to other states, maybe New Jersey next. So thank you so much. Do we have questions or comments?
If you have any questions, you can raise your hand. Just press the raise hand button next to your name, and I can unmute you so you can ask your question, or you can type it in the chat box.
So I'll ask a question to get things rolling again. And this is one that might have sort of I don't know how to anticipate an answer. Are there ways, or have you begun to look at what the impact of COVID has been on more classically environmentally associated disorders? So I think back, you're probably aware of our Environmental Occupational Health Sciences Institute here at Rutgers. Some of the members of that institute collaborate extensively with Phil Landergan, for example, and I know they have for years. And there are pulmonologists who were involved in looking at overall health as well as cardiovascular and pulmonary health in Beijing during the Olympics when they closed out all the traffic and people stopped having heart attacks and having lung problems. So the question of what happens when you shut down a city in like New York during COVID, has anyone begun to think about, because this could be double-edged sword, kids are also spending time now locked into their house instead of outside in conditions that may not be good. And then furthermore, complicating it, you don't go to an emergency room if everyone's telling you don't go because everyone there has COVID. But has there been any sort of thought process about how to look at the impact of the COVID shutdown, et cetera?
Yeah, thank you for that question. I think absolutely people have been looking at the environmental impacts of COVID and have specifically seen benefits in outdoor air quality with the reduction in traffic that was experienced immediately in the aftermath of the shutdown. And that happened not only locally, but internationally as well. And I think what it demonstrated to folks is that some of the interventions that folks have been advocating for a long time for climate change that folks thought were impossible, that with some creativity, that perhaps there can be ways to think about how to sustain some of those environmental benefits that have been seen. Unfortunately, it's come at great cost. So I think that there are challenges to maintaining some of those benefits. The other thing that it's demonstrated is that the public health importance of parks and how, in the time of the lockdown, the parks got incredibly crowded and everybody needed space to get out of their confined apartments. And yet it was challenging to find that space in the local parks, even in a place like New York City. So investing in parks and green spaces as a public health measure, I think there's a strong argument for that now in the time of COVID. And then on the negative side, the fact that people are confined to their homes and potentially suffering from increased exposures to things like peeling paint, mold, roaches, cigarette smoke, and other concerns is something that the environmental community is looking at. And we're awaiting the CDC data on lead poisoning. But the challenge to that is that at the same time, screening rates have declined because children weren't going to their primary care pediatricians. So there are limitations to the data. So I think there is some, just to end on a positive note to that question, there's some optimism about some of the environmental benefits that we did see. And I think it's important that the public health community comes out strongly endorsing those efforts.
Thank you. Other questions? We have one, where can we find the video format of Maya's lot in both languages? The question.
I'll share them in the chat. It's available both on the CURE website and our Mount Sinai website, and it's on YouTube as well. And so I'll share those links.
Fantastic, YouTube and Sinai. We should be able to find it then. Great.
Yeah, and we've taken that character and used her to introduce the My New York City Air platform, the open source platform. So it's like an infographic for students on how to use it and how to access existing databases. And Professor Bratsfies has also used it to teach families about the importance of the census. So that character is expanded. There's Maya's lot, and there's also Bina's plant, which is Maya's sister, the story of her sister.
That's terrific. Other questions? I'll continue. I'm very impressed by the real interdisciplinary nature of your group involved in research. But I'll continue mine in a second. Another question. What is the major environmental concern that affects children today, and what can we all do to address it? There's a big question.
Yeah, we've intentionally set our focus as healthy homes because that's a cross-cutting issue that affects families, whether you're in an urban, suburban, or rural environment. And it actually also affects families across the SES spectrum, but profoundly impacts families at the lower SES spectrum. So I would sort of say that's at the top of our list, and that hits a range of topics that I've mentioned in the talk. The top of the list, what I'll often say to families when we give talks to families is that environmental asthma triggers, lead, cigarette smoke, those are the top of the list, but you sort of, the families have to, it can be very overwhelming for families to hear us talk about all the exposures as I began my presentation, right? That toxic soup. And so what I say to families is sort of take the information and decide what's at the top of your list as a family and what you can make a meaningful change towards. And to also take the information and think about what you can do moving forward to prevent and reduce those exposures, rather than thinking retrospectively about exposures that may have happened in the past and what that means for your children's health. Because I often see families really struggling when they have a health concern in their child, that something that they did potentially caused harm to their child. So I try to take them out of that framework entirely, and that what we're doing is working together with them to try to prevent and reduce exposures. And that's the regulatory framework that we really want to see in the country, is that we are really rigorous about our approach to thinking through the neurodevelopmental reproductive health effects and the range of health effects in children before anything is put out on the marketplace, because parents shouldn't have to navigate this on their own. They need to know that things are safe before they're out in the marketplace.
Any other questions? I'll just throw in a comment too, and being among pediatricians here and at a Child Health Institute, the comment of kids not being little adults, of course, is a major sort of mantra of pediatricians. But here at Rutgers, and I think he's now moved, but Stu Shallot and Maya Ramagopal and the pulmonary group were involved in this little robot that would sort of crawl around on the floor sampling air, because the floor exposure of air, as you pointed out, is quite different, and the concentrations of LPS and of fungal antigens, et cetera, are very, very different. So it is a whole different discipline you're looking at. So anything else? We have thanks to you from several folks here. It's just a really great talk. And as I said, you're a storyteller. So thank you for telling the story. So we're coming to our last talk. Again, a pediatrician coming back to really bridging back now from different levels back to actually the genetics as well. So it's a pleasure for me to introduce our last speaker, who's Dr. Daniel Noderman. A number of you know Dan. I won't go into the details, but suffice it to say that Dan was a pediatric intensivist at Cornell, and actually then did a career shift that was really exciting, that I knew you at that point, learning some molecular biology and really basic biology, and then moved on to be chair here of pediatrics at Robert Wood Johnson Medical School, and founding physician-in-chief at Bristol Myers Squibb Children's Hospital, and was vice dean for research at Penn State, and has been at Princeton now for a number of years. He'll tell us about some of the work that he's been doing at Princeton recently. So Dan, welcome.
Thanks, Arnold. It's quite a pleasure to be here. And I have to say, I've enjoyed these talks so much, from Larry's at the beginning, who spoke about the expososome, and I'll try to talk about some of the biology underlying the important concepts that he discussed, to the talk we just heard from Maida, which relates where the rubber meets the road, so to say, where some of the basic principles that I've been trying to understand get extrapolated and translated into one hopes important advances for the care of the children we all loved. So my goal today is to first give a little course in Molecular Biology 101. I think molecular biology is something that everybody can appreciate, and that by understanding some basic biological principles, it becomes much clearer why the work of our colleagues that we've heard today in nutrition, environmental monitoring, in epidemiology is so important. So that's what I'll try to do in the next 40 minutes. Now, I'm going to show my acknowledgement slide first, so I don't forget to do it, in case Arnold rushes me along at the end. As Maida said, it takes a village. Funding for this work is mainly from the National Institutes of Health, but also the Russell Sage Foundation and Robert Wood Johnson Foundation. And we have a team of workers at diverse institutions in the United States who participate with us. And in fact, even at Rutgers, in the Department of Pediatrics, we have a collaborator, and I'll talk about some of the work with Manny Jimenez in a minute. So let me make this a little, I think that's probably better. So when I look out at an audience, which unfortunately I can't do now, but when I'm speaking, I see all kinds of people. I see tall people, short people, light people, dark people, happy people, sad people. And it goes without saying, I think everybody instinctively understands that there are genetic or hereditary differences that contribute to large measure in the kinds of differences we see here. What's well understood, but I hope to convince you, is that the kinds of differences represented now, geeks versus empaths, really smart, not so smart, people with high intuition and high scientific intuition, a lot of this can be explained by reference to genetic and, as we'll talk about, epigenetic modifications. And so I want to begin our biology course by looking at a cell. Now, Arnold, I know you know what kind of cell this is, but right, do you? This is a liver cell. This is a hepatocyte, and it's typical of the cells in our body. There are more than 400 different kinds of cells, well over 400 different kinds. And I put this here because I wanted to show you the basic architecture. Most prominent in the center is the nucleus of the cell. And it's in the nucleus that the DNA, that our chromosomes reside. So this is dark material is mainly DNA and some protein. In the cytoplasm are various organelles. The pretty red ones, energy, they're the mitochondria. And that energy is then used in part by the ribosomes, which make our protein. So this is a pretty standard picture of a human liver cell and its parts. Now, within the nucleus are the chromosomes. This is a karyotype of sorts in which different chromosomes have been painted different colors. And this is the usual appearance of the chromosomes. But when the cells begin to divide, the chromosomes condense and become more rigid, and you can actually look at them and inspect them. And using modern spectral techniques, you can actually paint them different colors. So we have 23 pairs of chromosomes in every nucleus of every cell in our body. We have one set here and here and here from our mothers and one set from our fathers. These are the sex chromosomes, and this is a genetic male because there's an X and a Y. So this is called a karyotype. Now this baby, I'm not sure why I have that tag there. This baby has a different number of chromosomes. This very pretty child has 3 chromosome 21s, and that's because, of course, she has trisomy 21. You can see she's very happy with herself nonetheless. And I want to show this slide just to point out that it's really a minuscule difference between children with trisomy 21 and children who don't have trisomy 21. Now, the chromosomes, which are part of the nucleus, so here's a picture of a nucleus here inside the cell. The chromosomes inside the nucleus are composed of DNA, deoxyribonucleic acid, as you can see in its typical helical conformation. There are about 2 meters of DNA, 6 feet of DNA in each of our cells. Each of our DNA, each of our nuclei has about 3 billion base pairs, DNA subunits. These are the A, T, C, and G that you've probably heard about. And altogether, within our DNA, within our chromosomes, there are about 25,000 genes, just about the same number as our friend, the mouse. The DNA in our nucleus gives rise to a molecule called RNA, and the RNA in turn is translated to form our proteins by the ribosomes I showed you before. Now, even though everybody has DNA, and our DNA is pretty similar, as a matter of fact, since we've really understood this since about 2000, our genomes are permeated by single nucleotide polymorphisms, which we can call SNPs. And a SNP is just a single base pair change. So if a gene has this sequence, Gattaca, let's say, in one person, in another person, it might have this sequence, Gattata. This would be a C to T change. And these two forms of the gene are called alleles of the gene or variants of the gene. And it's these kinds of differences in our genes which accounts for the way people look. So one form of Gattaca might code blue eyes and the other brown eyes. So here's the change from a G to an A. The current count, I'm just going to try to exit here and get rid of this thing if I can. I don't. There we go. This is some kind of Zoom thing that doesn't want to go away, so I'm sorry. Okay. So the current count is that there are about 60 million SNPs, 60 million variants in the human species. Now, if you do the arithmetic, you'll understand that about 98% of our DNA is the same. So about 98, it's actually 98.5% of the DNA between me and Arnold is exactly the same sequence of the 4 letters. The same proteins are made. But this still means, because there are so many billions of base pairs in our cells, that there are more than 50 million chances for us to differ. And these 50 million differences between this woman and this gentleman, for example, between each of these people, right, together with other differences we're not talking about, explain individual susceptibility to disease, response to drugs, or reaction to the environment. So the way we look is our phenotype. That's the appearance of the organism. And in this cartoon, the Shanahan from the New Yorker is just pointing out a commonplace fact that fathers and sons often look alike. They often share phenotype, and they share phenotype because they share genotype. Now, variations in SNPs, whether you have a T or a C in a particular part of your gene, are inherited regionally. So they can be used as a marker of ancestry. And this is what Ancestor.com does or 23andMe does when you send them a little saliva. They're measuring your SNPs using the same kind of chip we use in the lab. And because of that, and because people, for example, in Poland have a certain kind of distribution of SNPs, and people in Romania have a different, they can tell where your forebears arose, what the ancestry was. This is actually a map of Europe, but it's a map that's done by looking at the clustering of SNPs. And so you see clearly that the British can be distinguished from the French, I'm sure they're happy to know this, by different patterns of DNA. Now, even in modern Europe, where there's been so much migration, these differences are really very finely graded. So somebody who lives in Munich, Germany, and someone who lives in Dresden have different patterns of these SNPs and can be distinguished by measuring these SNPs. Now, SNPs do not only give us traits, how tall we are, how the color of our eyes, but they're also linked to diseases. So each one of these structures is a chromosome, right? Less the sex chromosome. There should be 22 here if I did this right. And each one of these dots is a different disease that's been tied to a region of the chromosome. The color tells you what kind of disease it is. So as of May 7th, 2018, these are all the genetic diseases of humankind that have been tied to a specific SNP or mutation. And I just put this picture here. This is of blood taken from a child with sickle cell disease. You can see the sickle. This sickle cell disease is caused by a single mutation, a single SNP in the hemoglobin protein, or in the gene coding the hemoglobin protein. So these SNPs both give us our traits, but they also unfortunately give us many of our inherited diseases. So that is the genetics component of Biology 101. And now we're going to talk about another property of DNA. I want to try to answer part of the question of how we get from this cell, which is a just fertilized egg, to this cell, which is a liver cell. The DNA in this nucleus is the same sequence, right? The same ATCG as the DNA in this egg's nucleus. How come this cell looks so much different and functions differently? And how do we account for the other 400 kinds of cells in the body that all derive from this one cell? How do we get from this to that? And part of the answer to the question is now coming into focus, and it has to do with chemical changes that can occur during life to the DNA. So if this is a little strand of DNA with a C, G, A, T, T, for example, the C residues, the C part of the DNA can easily be methylated, have a chemical change where this atom is changed to this structure, like this molecule. It's called a methyl group. And this methyl group can be placed on in different patterns. Here it's this pattern, but it could have just been these two here. And it turns out that the pattern of methyl groups radically changes the way that the DNA functions. It radically changes the phenotype. That kind of change, right, chemical compounds and proteins that attach to DNA, is called an epigenetic change. And just as we have a genome, which is the sequence of DNA, and a phenome, which is the appearance of the organism, so we have the epigenome, which is the totality of changes to the DNA that methyl groups and others can accomplish. Now, this looks complicated, but it's actually very simple. This is a diagram showing what happens after an egg is fertilized, as it grows and divides in the mother's uterus, as it becomes a person, a little baby. And, oops, excuse me. And this, what happens after the baby is born. Baby grows, matures, becomes an adult, and then gets old and ultimately dies. I like to think of myself as over here, although I'm pretty sure my students think of me as over here. But in any case, the changes that are occurring progressively in both the development of the organism and the aging and ultimately senescence of the organism, to a large extent, are due to systematic and systemic changes in DNA methylation. And just to keep it simple and keep it moving along, this is an experiment taken on tissue from the brain of different individuals, measured for how much methylation there is and how much change there is, how fast the methylation is changing. And you won't be surprised to see that methylation changes most rapidly in the fetus in this period of life, but continues to change during development. Once you reach adulthood, really it's post-puberty and post-maturity at around 18 to 20 years of age, the changes in methylation slow down, but they're inexorable. And it's in fact the change in methylation as you age that to some extent seems to account for the aging process. Now, in addition to DNA methylation controlling development and we think senescence, it's also part of the response system to the expososome. It's one of the ways by which environmental exposures, such as have been so elegantly discussed, and nutritional exposures, which have been discussed today, it's one of the ways that the expososome affects our phenome. In other words, it's one of the ways that the social determinants of health get under our skin. It's one of the ways that poverty and ACEs and deprivation and even good environments affect our biology over the long time. Now, I want to just mention one more bit of biology, and then we're pretty much done with Bio 101, and you'll have your final exams in a moment. I want to mention another structure called the telomere. The telomere is the tips of our chromosomes. So here's a chromosome, everybody recognizes it. The red part is our genes, and this green part, the tips are the telomeres. The metaphor is like the tip of a shoelace. Now, as a person ages, the telomeres on their chromosomes, going from 0 to almost 100 here, the telomeres get shorter and shorter and shorter. This material is used up during the process of aging and development. And in fact, this is a sort of aging clock. By knowing someone's telomere length within a wide range, you can estimate what decade of life they live in. Now, a number of years ago, a scientist named Alyssa Appel made the interesting observation, which I believe has been substantiated many times now, that the perception of stress or the environment that goes along with stress seems to affect telomere length. And so this is an experiment in which women who were caregivers for a very sick person rated how much stress they were under. And as you can see, the more self-rated stress these caregivers were under, the shorter their telomeres. And so actually a whole science, some of which is very good and some of which is not so good, has evolved in which the shortening of telomeres is taken as a marker of stress or other adversity. So now I'm going to come to the main topic, and that is the Fragile Family Study. The Fragile Families and Child Wellbeing Study was started by investigators at Princeton and Columbia University, Irv Garfunkel at Columbia, Sarah McClanahan at Princeton, and others at collaborators at both. Started this study in 20 large US cities, greater than 200,000 population. There were about 5,000 births. It was a probability sample in which single mothers and poor mothers were favored for inclusion in the sample. So there were about 3,700 non-marital births, excuse me, and 1,200 marital births. The cohort is about 47% Black and 20% Hispanic, 20% white, 21% white. These individuals are by and large poor. The poverty ratio is only 1.4, which is quite low. 35% have less than a high school education, 30% have completed high school, and only 24% have some college. So this is a stressed, poor, largely inner city population where 2/3 of the children that we're going to be studying were born to single parent households. The study components are shown here, and I won't review them in detail except to say that we've been in the field multiple times, and we're in the field again now at age 22. And each time the mother was surveyed in detail, the father was surveyed, this is the biological father, was surveyed in detail, and also the child received an assessment, sometimes in home, sometimes by a survey. There were also teacher surveys and environmental surveys. We know a lot about the environment these children live in, both the social and the physical built environment. At age 22, we're back in the field. We're doing cardiovascular exams in these young individuals now, including blood sampling and echocardiography, et cetera, because of the close link between poverty, social disparities of health, and premature heart disease. So we've been funded to try to quantify and better understand that. So one of the early biological studies that came from fragile families, and I didn't emphasize, and I should have, that at age 9, age 15, and now at age 22, we collected DNA from these children and from the mothers. And these collections have fueled the experiments I'll talk to you about now. This was one of the early studies that we did called on postpartum depression, and the study was one in which we compared the risk or probability of postpartum depression with the socioeconomic status of the mother, ranging from a poor woman, a woman from a poor family, to well-to-do families, where there was plenty of money, stable household, to women who had considerable intolerable material adversity. And we also stratified these women by genotype, by the kinds of SNPs and other changes that they had. And we knew from other literature that there is a way to categorize people into two genotypes: those who are likely to be highly reactive to the environment and those who are likely to not be so reactive to the environment. And this mainly has to do with interactions, excuse me, with changes in the serotonin transporter, which is the target of many antidepressants, including, for example, Prozac. And one of the intriguing things we found is that in women who were highly reactive, and by that I mean they have high genetic reactivity, high predicted by their genetics, in this transporter, the usual relationship women who are economically challenged, who suffered material hardship, were likely to become women who had material advantage, well. Hello. Hi. Arnold, can people hear me? I was kicked off.
Yes, we can hear you now.
Okay, sorry about that. Let me reshare my screen. Wow, you'd think I was on the moon and I'm only over here in Little Cranberry. Can folks see again, Chris?
Yes.
Okay. All right, so the point I was making is that women who had material hardship had the expected relationship, right? Women who had high genetic reactivity had the expected relationship between material hardship and the rate of probability of postpartum depression. Women who seemed to not have this reactive form did not respond in any way to the environment in terms of postpartum depression. And this was an example which was published in PNAS almost a decade ago now, of the so-called orchid dandelion hypothesis, that there are individuals who, because of their genetic endowment, have a temperament such that they're more likely to react to the environment. So individuals who are very sensitive, reactive, able to incorporate environmental cues are called orchids. They're called orchids perhaps because they're beautiful, but they're fragile. Dandelions, like most of us, are not quite as sensitive, but they're sturdy and they don't need the kind of stable environmental signals that the orchids do. So I mentioned this because it's going to come up again in a couple of papers that some data that I'm going to show you. Okay. So we've talked before about adverse childhood experiences, and here I'm talking about parental divorce, family and neighborhood violence, mother's depression, material hardship and poverty, the sorts of things that all of those working in child health are concerned about. And this was a study which I did with colleague Coulter Mitchell in Michigan, again, stratifying children by the number of sensitizing serotonin genotypes. Right? Remember, this is the target, right? This gene that we're looking at here is the target of the antidepressants. And we looked at children whom we classified dichotomously as either in an advantaged environment, in dark, or a disadvantaged environment. Advantaged meant they didn't have many ACEs, right? They didn't come from a violent neighborhood. Their parent had a stable relationship. Their mother had a stable relationship with a male. She was not depressed. There was plenty of money around, that sort of thing. Disadvantaged was the opposite. And as you can see, if you're advantaged, the more sensitizing alleles you have, right, the longer your telomeres, right? Presumably less adversity communicated to your cells in these individuals than in these individuals. But if you're disadvantaged, the opposite occurs. Right? The people here who don't have the sensitizing genotype are not much affected, but in the disadvantage, the more sensitizing their genotype, the more adversity is communicated to their cells, and that's reflected in shorter telomeres. So these signals go in different directions, right? If you're sensitive, an orchid, a disadvantaged environment is bad for you, and an advantaged environment is good for you. If you don't have the sensitizing genotypes, not so much. Now, remember, we're talking about the family environment and the social environment. We're not talking about the physical environment. We're not talking about pollution. We're not talking about poor nutrition. We're talking about relationships between people. And somehow, the way that these relationships affect children seems to be at least genetically moderated. So this paper caught a lot of attention. It was just published a couple of years ago. We wanted to see what the effect of losing a father was on one of our children. And because our children live in mainly an inner city context, many of them lose their fathers even after they've been acquainted with them early in life. So we looked at whether or not a child had first had exposure to her father or his father, and then lost the father before the age of 9, either through divorce or separation, through incarceration, or through death. And the first thing I want to show you here is that compared with children who had no loss, right, children who lost the father had shorter telomeres. And of the 3 categories we looked at, death was the most potent in this regard. Now, this may not look like much, but this is actually a big shortening of telomeres. It's many, many years worth of telomere shortening in the normal process. So children whose fathers died had some of this adversity transmitted to the function of their most basic cellular elements, their chromosomes and genes. Now, in this figure, which is the same data, you see a couple things. First of all, we've changed this, and now we're looking at how much shortening there was. So boys had a 20% shortening of telomeres by losing their father, by virtue of not having their fathers, whereas girls had an 8%. So this is not unexpected, right? A boy who loses his father, especially before the age of 9, is facing perhaps a greater adversity than a girl who still has her mother. And the second is that this old friend of ours, the serotonin sensitizing score, the genetics of temperament, seems to also be involved. Those who are not particularly, do not have a sensitizing allele, not so much of an effect. Those who have the most sensitizing alleles have the largest effect. Okay? So this replicates, once again, this interaction between the environment, the genotype, and the effect on the child, the phenotype. This was a large study, so this data is pretty solid. And again, we have our orchids and our dandelions. Sturdy but dull orchids, beautiful but sensitive dandelions. Okay. Now, this study, one that we completed at right here, actually, at Rutgers with Manny Jimenez, again, showed this interaction. So Manny was interested in seeing how well reading at age 1, right, sustained reading at age 1, how that correlated with one's verbal ability at age 3. And he found that the more the parent read with the child, right, the higher the score on the vocabulary test at age 3, no surprise. But he also found that this was genetically moderated. These are the same patients, the same subjects we've been talking about. If you read 7 days a week, right, there, let me put it to you differently. If you had a sensitizing allele, right, there was a big difference between not being read to and being read to. If there's no sensitizing allele, it didn't really matter. So reading is an important way of mitigating or moderating the effect of sensitizing genotype in children. This was published this year in the Journal of Pediatrics. Now, what time do I have, Arnie? About another 10 or 15 minutes or 10 minutes?
About 10 minutes.
Okay, so I think I'm gonna go through this quickly. You may have heard of the Dutch hunger winter. I'm sure the nutritionists here have. There was a famine in Holland that the Nazis induced to punish the Dutch, and many people, including pregnant women, had extreme deprivation. I'll have to skip my video, but in parts of the country, but not in others, the daily calorie ration fell to 600 to 700 calories per day, and this affected pregnant women also. What was found among the children who survived and were later, for example, inducted into the army at age 19 in the 1950s, was that when a fetus was exposed to famine in the first trimesters, those fetuses, when they were young men going in the army, 80% more of them were obese, were overweight, than if they were not exposed to famine. So there was some long-lasting, 2-decade long effect on these children, and it was the opposite of what you might have expected. The fetuses that were starved were the ones that 20 years later were the heaviest. More importantly, perhaps, is when you looked at these individuals as older adults, the hazard ratio, the risk of mortality cause in women much more than in men. Now, these women were fetuses when they were exposed to the famine, 1.9 times, hazard ratio is 1.9 times greater for overall adult mortality by the time of examination, 4.6 times greater heart disease, 2.3 greater cancer, including an 8-fold increase in breast cancer among these fetuses who are now adult women who had been starved. If you look at their methylation patterns, and remember I talked to you about methylation, you see that of the individuals who were most starved, those are the ones who were fetuses here, there were pronounced increases in DNA methylation, many of which involve metabolism. So for example, this is the insulin receptor. So the take-home lesson from this is that an abnormal environment, starvation, in the first 2 trimesters of pregnancy puts a lifetime tag on the baby and disturbs the baby's metabolism for the rest of her life. That seems to be due in part to robust and continuous changes in DNA methylation. Okay. You can show this. This is an experiment in my laboratory where our furry friends, these mice, were put into what's called a chronic restraint model. And this is the amount of methylation in the hippocampus, or the part of their brains that is involved with emotive and stress responses. And you can see that stressing these mice by restraining them over a several-week period greatly increases the methylation signals in their hippocampus. And we believe that this accounts for some of the behavioral abnormalities in these animals compared to control. It's being explored now by a very smart student. Okay. So back to fragile families. You remember I showed you the earlier study where we looked at telomere length in the ACE sample, children who had really terrible environments when they were brought up and children who had pretty good environments when they were brought up. And not only do we look at telomeres, but we looked at a global index of methylation. So each one of these rows here across is the methylation of a different part of our genome. And each one of these is a person, is a child. And you can see, first of all, that using a computational program, there's a perfect separation of the children who lived in adverse environments and the children who lived in good environments. And that persisted up to 15 years after birth, just looking at a few hundred probes. So there's a clear methylation signal, a clear signal that affects how the DNA is expressed, affects how our cells work and reproduce themselves and function. And this is affected by adversity in childhood, and it persists. So I think I'll give you 1 or 2 more examples and then we'll wrap it up. Just as reading seems to be able to mitigate the deleterious effects, if you want to call them that, of a sensitizing genotype. We also find that maternal attachment to a child can help smooth some of the methylation effects of poverty. So in this study, Kelsey Koss, who was a postdoc in my lab, she's a developmental psychologist, assessed the poverty status of the children at birth, did an analysis using a survey instrument, whose name I can't remember right now, of parental attachment at age 3. And then we measured a term called the epigenetic age at 9 and 15. So it's possible to estimate what somebody's biological age is by looking at methylation. And then she calculated a term called accelerated aging, which is basically the change in epigenetic age over the change in chronological age. And you would expect that term to be 1 if your aging or your pace of aging biologically is greater than chronologically, this term will become positive. And so here's what you see. First of all, she found that if the mother, we also did this in the mothers, if the mother was married at birth, the child's pace of aging was slowed, right? So more negative. That says that stable homes, and marriage is one form of having a stable home, it's not the only one, but stable homes seem to be associated with less rapid biological aging in the child, not unexpected. She found differences in the rate of aging in Blacks and Hispanics and whites. I'm not sure what this means, to be honest with you, and I think it's probably an artifact. But this is the take-home message. For children who are born at or below the poverty line, compared to those born above, we see clear evidence of accelerated aging if there was a poor relationship, poor attachment between the parent and the child at age 3. On the other hand, if good bonding had occurred, if there was good maternal and paternal attachment with the child, the pace of aging was slowed. Here, negative is good. So once again, attachment, right? Involvement of the parent with the child seems to mitigate the adverse effects in part of a poor environment. For children who are born relatively well-to-do, it's not that important, not a surprise. And then a couple of things about pollution, I'll wrap it up. First of all, we know that smoke exposure in utero clearly affects the metabolism of the child. We all know that as pediatric specialists. Here are some of the genes that are involved. These are children compared, this chart compares children whose mothers smoked with those who didn't in utero. And you can see a number of genes whose methylation patterns shown here are abnormal. And perhaps more clearly, if you use an index called the methylome pack year, right, a methylation measure that correlates with pack years of smoking, you see extremely high coefficients at age 15 and age 9 for smoking with extremely low p-values. This is telling us that the effect of maternal exposure on the fetus is still present, still as powerful at age 15 as it was at birth. These signals never go away, actually. They're present in adults. And finally, when it comes to airborne neurotoxicants, we know from Fragile Families that the more exposed our children are to neurotoxicants, the lower their cognitive abilities at age 9 and 15. It's a fairly strong relationship. Here's the beta. It's a significant relationship. And we can show that some of this seems to be due to increases in certain genes that are associated with the presence of neurotoxicants in the atmosphere. Okay, here's my take-home message. While genetics shapes potential, and epigenetics responds to the physical and social environment, producing the final phenotype of health, wellness, or disease. But neither genetics nor environment is destiny. Both fixed gene effects, the SNPs and others, and DNA methylation changes can be buffered by parental attachment and early intervention. And for my little friends in Laos, thank you very much. Okay.
Terrific talk, Dan. That really brings us full circle back to the actual biology of the child, of all the different influences we've been talking about today. So systems on systems on systems coming back in the end. Are there questions for Dr. Noterman, please? For absorbing the biology lesson and translating it then.
Well, it was a lot of biology, but I think most people get it.
Yeah. Well, what I love about molecular biology, you can draw it and show the pictures. So I have the benefit of some inside knowledge, but could you talk about what you might anticipate in the next generation of the Fragile family? The kids who are now in their 20s will be having kids.
Right. So, there was somebody I didn't mention, and that's Nancy Reichman at Robert Wood, who actually joined the department when I was chair. And Nancy is a health economist. She was one of the people who started Fragile Families. And she and I still collaborate. And right now, Nancy and colleagues at Columbia are leading an effort for us to continue to study the grandchildren. In other words, the children of the Fragile Families. And it provides us with a really unique ability to understand how the environment, genetics, and epigenetics all affect pediatric health, children's health, and to see ways in which they can actually be transmitted from generation to generation. So that's the baby project that's coming up for funding, we hope soon.
I point out that Nancy and Manny are both also members of the Child Health Institute, so we're delighted to be fostering this as well. So I had a little inside information there.
Yes.
We have a question, it looks like. Question from Lisa M. Do the genetic studies take samples of blood, saliva, or cheek swab?
The studies that I told you about from Fragile Families all used cheek swab, not cheek swab, saliva, I'm sorry. So these are saliva studies. In the next generation, we'll be collecting, at age 22, we'll be collecting blood as well as saliva.
Other questions? I guess I will ask the question that's unanswerable, but how do you get from an adverse childhood event to a change in methylation?
Well,
sorry.
Well, it's a great question. So, I mean, there are lots of answers. Some of them have to do with, endocrine modifications to methyltransferases. That can be detected in the laboratory, but to my knowledge, have not really been well established in vivo. There are also changes that, probably changes that occur in the central nervous system. So the principal form of methylation in the brain is not methylcytosine, it's hydroxymethylcytosine. And those changes, again, are driven by methyltransferases and demethylases, but the exact connection between activation of the sympathetic nervous system, steroid hormones, it's not really clear. And so, we're trying to understand some of that in my lab. That was the purpose of that mouse experiment, right? The plan is to show that there's an effect, and then we can begin to try to understand it mechanistically. And someday, if you invite me, I'll tell you about the research I'm doing with Schenk on cytomegalovirus and human telomerase, because that gives a clue also as to how there's a bridge between the environment and what's happening in the cell. It's not at all clear. It's not simple.
No. Any other questions? I think this really points to the tremendous effects that we have on the child and child well-being development from every level. And talking from governmental, societal, environmental, families, schools, at every level. And as you pointed out, there's the potential to have things happen that are not necessarily health promoting, but also the potential for interventions that can mitigate significantly some of these problems. So it's our responsibility to try to mitigate these and to try to avoid them. And hopefully the more we learn, the more we'll be able to examine how systems can be modified in ways that are helpful to children's development. So with that, I will sort of sum up and wrap up and thank everyone here. I'd like to ask Mara before we go if she has any comments administratively. I'd like to say anything to participants. I know there was a survey form, etc.
Yeah, I just wanted to just reiterate that, I don't know if I can, there we go. Just thank everyone for registering beforehand and for participating for our symposium today, and to not forget to complete your feedback forms that we had sent out prior to the start of the symposium, which included the link that you can fill out your form electronically. And I think that's it. Thank you everyone for coming.
And I will add my thanks to everyone for coming, add my thanks to the speakers and panelists for a wonderful day, tremendous presentations and discussion. My thanks to Mara, Chris, and David Kroll for helping put this together, as well as to Larry, who also helped put this together. And finally, thanks again to the Robert Wood Johnson Foundation, who sponsored this and this whole series, as well as the NJHKI. And you can see that there. So thank you all very much, and have a wonderful weekend and a healthy and happy rest of the year and into next year. We'll see you again. We'll have another symposium, hopefully in the spring. So please keep your eyes out. Thank you all.